Good evening, sir. Dabba sir ki jai.
Kulranjan, it's all recording actually. So thank you so much. But this one, Talapati sir has joined, Bharat has joined, Ganesh has joined, Spandana has joined. Rinal is on the way actually. She's coming here. She's finished her surgery. So Ashwini has joined. So we can start actually, and Kailash sir also, one rapporteur has joined. So there is no audio is not, I'm not audible.
You're audible, sir.
Okay. Because Kushagra has written.
So Professor Sabaratanam, you are well audible.
Ma'am, you also are making fun of me.
Voice not coming.
No problem. Like
Voice not coming.
I am audible. Sabha, I am audible.
yes, sir. You are audible, sir.
Good
Okay.
evening, sir. You are well audible.
Good evening, Pooja. Good evening. I am logging from my iPhone actually. I'm another person's house. So for some urgent work, so I can log in from this
Okay, sir.
iPhone. Okay.
Sure, sir.
So we will, without wasting time, we will start actually. And today is the 4th day of National Conference of Rural Surgeons of India, and we have with us the endocrine surgery session, and all endocrine surgeons are available. Most of them are well known to everyone in the country and also internationally. So without wasting much time, I will introduce two rapporteurs for this main session, like Professor Bhargav, who is a senior endocrine surgeon from Vijayawada, and Professor Kailash Mohapatra sir, who was the past president of IAES. So, and this session will be moderated by Dr. Kulranjan Singh, Professor of Endocrine Surgery at KGMU, and Professor Talabadi Sadacharan, who is the HOD of Madras Medical College. And then we have Dr. Kushagar Gaurav, who is the additional professor of surgery at KGMU, Dr. Spandana Jagannath, who is an assistant professor, Dr. Ganesh Bhatt, again associate professor of endocrine surgery, and Dr. Ashwini Rahalkar, who is an assistant professor. These people have joined already. So without wasting much time, I hand over the thing to Dr. Bhargav sir and Kailash sir to further take away the procedure.
Yeah, good morning, all of you. Am I audible, Sabha?
Yeah, you are audible.
Yes, sir.
Yeah, good morning, Kailash, Dr. Kailash,
Yeah, good
and all the participants. Welcome to today's panel discussion on evaluation and management of solitary thyroid nodule. As all of you know, solitary thyroid nodules are common yet intriguing clinical entity in clinical practice, with prevalence increasing due to widespread imaging and heightened public health awareness. Although most nodules are benign, the need to distinguish low risk lesions from thyroid cancers remains central to the patient care. Our discussion featuring distinguished galaxy of faculty will explore current diagnostic pathways, including risk stratified assessment and expanding the role of molecular testing in guiding optimal therapy for solitary thyroid nodules. We will also review the evidence-based management strategies ranging from active surveillance to minimal invasive approaches and indications for surgery. I ask the delegates and participants to be interactive and pose as many queries as possible to extract best possible outcome on this important clinical condition of STN. So let us set the ball rolling. And now I urge, after Dr. Kailash sir's signal, I'd urge Dr. Kulranjan, the moderator, to introduce the panelists and conduct the panel discussion.
Professor Kailash, sir, can I take over?
Yes, Kullanjan, you can go ahead. At the outset, I thank Dr. Savaratnam for organizing such a very nice academic extravaganza. The Association of Rural Surgeons of India is really, yesterday I attended the plastic surgery. It was so interesting to hear, and so many learning experiences I had. So today we have with IAES and Rural Surgeons of India, we are organizing this. We have lined up learned experts will be speaking on salted thyroid nodule. So without wasting any time, I'll request Dr. Kullanjan to take over and start the session.
Thank you, sir. I'll just share my screen. Is my screen visible?
Yeah, it's visible. Yeah.
Visible.
Visible. So, good evening, everybody. And thank you, Sabha sir, for getting us on this platform. So this is going to be a panel discussion on solitary thyroid nodule. And I've kept it as a casual conversation amongst performing urban surgeons. And our distinguished panelist, we have Dalapati sir. So D for Dalapati, D for Don, and D for Doyen of endocrine surgery. But I just guess it's a spelling mistake was there, and it's not D, and it is T Talapati, and Talapati apparently in Tamil means the leader. So it will be Dalpati sir who will be actually the showstopper, and he'll kind of summarize everything for us. Or any doubts that we have as a panelist, his word will be the last in this panel discussion. And along with Dalpati sir, we have our most intelligent Dr. Kushagar Gaurav from KGMU, Lord of Wisdom Dr. Ganesh from SAFI, and our throbbing Dr. Spandana, our Italian queen Dr. Rinel. Dr. Mithun is not there currently. He's in the OT. Apparently Mithun means union, and he's operating a bilateral adelectomy just now. And of course, Dr. Ashwini, who can control anything and everything. So welcome one and all. And looking at the session, कि this is a session between Association of Rural Surgeons and IAES. So I was just thinking, is it a hypocrisy where a group of urban surgeons and specialists are talking in a forum for rural surgeons, but definitely not, because I'm going to contradict this. And this morning I came across this to get away with my habit of procrastination. I was reading this book, and the postscript says, if I don't contradict what I say, I'm stupid. So I'm going to contradict everything that I normally say. And even the panel discussion is going to be about this. We may say that this is the most ideal thing, but finally, when we manage the patient, it may be quite different from the most ideal thing that would have been done. And this is very relevant when we are speaking to a group of rural surgeons who normally function in an setup which is often compromised. So do I contradict myself? Very well. Then I contradict myself as I am large and I contain multitude. So this was a famous saying by Walt Whitman, who was an American poet. So contradicting what you say is almost a human practice, and it is almost present in 100% of the individuals. So what we say in one case may be actually diametrically opposite of what we do in another case. And with this, I would like to take forward. So not many disclosures, but then at the outset, who is the rural surgeons, or what is the definition of a rural area? So even in our country, if we see, for any population or a village that is limited to 5,000, we categorize that as a rural area. So if we go by that definition, even Ames, Devgarh, which is in village Devipur, actually falls in a rural setup. Or even the famous Ames Kalyani in West Bengal actually is in village Saguna. So these are again villages where we have the most advanced setup. And even if we go by that, what the Association of Rural Surgeons was a big leap forward, formed in the late 80s and 90s. But the situation is a lot different, where almost in states like Haryana, where almost 98% of all the villages are connected to the city by motorable roads. So this concept needs a change. Nevertheless, we have an galaxy of eminent endocrine surgeons where we may be practicing the latest guidelines, but we have to come down to a bare minimum what should be done in a resource limiting setting. So we'll try to get that out of this panel discussion. So the first case is a 35-year-old lady who has a swelling in front of her neck of 2 years duration, gradually increasing in size, no compressive symptoms, and she does not have any history suggestive of hypo or hyperthyroidism. So with this, I would just like to throw the first question to Dr. Kushag. In such a scenario, what are the clinical points that you would normally look for to take things forward?
The clinical, of course, clinical examination, as you told, she's a lady who is hailing and she's having 2 centimeter nodules approximately with clinical euthyroid. So I would definitely counsel her for surgery and further evaluation, the diagnostic evaluation and further workup for surgery, sir.
So needless to say, this merits clinical evaluation. So what I just wanted to point out, are there any clinical features, assuming that we are practicing in a resource compromised setup, or let's say where the patient may not have access to the best of things immediately? Are there any warning signs that you would look for in the clinical examination and speed up things, or we can take a step back and take things gradually? That's what I was hinting at, Dr. Kushag.
Yes, definitely. There are certain risk factors where I would think that patient would warrant a rapid clinical workup or a diagnostic workup. In such cases, if the patient is having in extreme of ages, like if patient is very young or a male patient, elderly age group, or the nodule is hard, having multiple lymph nodes like that, and if there is voice change, there is a short history of rapid increase in size. In such cases, I would think that patient might be having harboring a thyroid cancer. So in such cases, I would like to speed up the diagnostic workup.
So if I had just to again turn this question to Dr. Ashwini, will we press the panic button in all cases if we have some what you call logistic issues, or there are some cases where based on certain features we can kindly slow down our diagnostic approach? Dr. Ashwini.
Am I audible?
Yeah.
Not in all, like a few cases, in cases of thyroiditis, they may have restricted mobility clinically. It might be suspicious of malignancy. However, we can evaluate for signs of hyperthyroidism, and based on the thyroid profile function, we can assess that. And even an ultrasound is a good enough modality for us to either suggestive of features which may or may not be hinting at malignancy. So not in all cases we need to have a panic button, but in maybe elderly patients, male sex, yes, we might think more in terms of malignancy.
So Dalpati sir, what would be your take? Can there be a subset of patients, let's say for someone who's practicing in the PHC or the CHC, where they can follow up the individual without any further clinical evaluation? Sir, your take?
Thank you, Kulranjan. If the nodule is actually static and if has been even static nodules can also be malignant. But whatever be the nodules, it needs evaluation. Whether now even in the as far as even in the remote places, ultrasound is freely available. So better we go with the basic TSH as well as thyroid function test and then ultrasonography of the neck. If suppose ultrasonography of the neck is not available, if there are no pointers as malignancy as Kushag told, we can even wait and follow it up also. But we need anyhow definitely evaluation with an ultrasound and a thyroid function test. And based on the ultrasound, we can go for a FNAC of the thyroid nodule if there are certain features suggestive of malignancy, as Dr. Ashwini also has told.
Thank you, sir. So, the take-home message should be in today's times, once we come across a patient with a thyroid nodule, which is of a significant size, more than 2 centimeters or so, they do merit initial diagnostic workup in form of an ultrasound and a TSH plus minus FNAC. So with that, I'll just throw the next question to Dr. Enel. So what is your take? Should be any specific sequence of these investigations, or they can be ordered in one go? What's your take, Dr. Enel?
Thank you for the question, sir. So I would like to order everything in one go because of logistic reasons that we face here, even in an urban setting. So I wouldn't want the patient to come more than probably 2 times to me with before I make a diagnosis. So I would like to do a thyroid function and an ultrasound. And if I already my pre-test probability that this patient is going to get operated, I would actually like to do all the tests related to surgery even.
So Dr. Enel, am I correct if you already are preoccupied with that, you're going to operate this patient for sure? Is that
No,
what
I'm saying if my pre-test probability is high that I would like to operate on this patient, I would also get those tests done. So the patient doesn't have to come more than once to the hospital, more than at least 2 times to the hospital before we decide on operating.
And so you'll order, but what would you prefer? First an ultrasonography, or you will get an FNAC done in all cases?
So first, I would definitely like to do an ultrasonography, and then if there are any suspicious features or any feature suggestive that I need to do a guided FNAC, I would definitely do a guided FNAC in the patient.
So I do understand you have worked at the best of hospitals, done your training at Sir Gangaram and then subsequently at SGPJ. Do you personally think that ultrasonography is widely available in the rural setup, and we can trust those reports, or you think the system is a lot compromised? Just a personal take. I'm not asking for data or things like that.
So I think ultrasound is available, but you're correct when you say that we may not be able to trust the report. So even though an ultrasound is done from outside, we don't know who's reporting it and the caliber of the person reporting it. So I would want to get another ultrasound done, or even do the ultrasound myself.
Okay. So if there are any specific clinical features on ultrasound that would actually make you more suspicious, or any single most feature that you look which you would give the highest score to in your ultrasound report, that the patient merits an FNAC, what's your take on that? Let's say it's a
So I
compromise,
think,
but
yes,
there
sir.
are some things, some keywords that you would look at.
So I think the alarm bells would ring if, first of all, there is extra thyroidal extension. And then, secondly, say there isn't, then I would say microcalcifications, taller than wider, very hypoechoic, and a solid component. These are the things that we need to see, which would raise suspicion for malignancy.
So I would again just throw this question to everybody in sequence. Dr. Kushag, are you satisfied with the kind of patients who walk into your OPD with the kind of reports, ultrasound reports they have?
At times, I would say yes, sir, logically speaking, because the crowd that we attend and the working in a institution like KGMC, we get very long reports. If I want to get a report of ultrasound, it would be dated at least after 2 months from our institution. So we personally kind of believe we try to correlate the ultrasound finding that patient is having with the clinical findings. If we find it sufficiently enough, then we go ahead with the guided FNAC or and further workup.
Now, what I asked, are you satisfied with the ultrasound that is performed in the community, or let's say specifically over here at smaller centers or in the rural setup?
Mostly at times, yes, sir. Mostly at times, I even see they are reporting even TIRADS at times. TIRADS 2, TIRADS 3. So at times, most of time, 70, 60, 60 to 70% times, I feel they are fine enough just to correlate the findings.
Dr. Ashwini, your take?
So most of the times, actually, we do prefer having a repeat ultrasound at our place. Only in very few cases where our clinical features and the ultrasound is very well correlated, maybe only then we let go of the ultrasound. Otherwise, I would personally prefer getting it done from our own institute or doing it myself.
Dr. Spandana?
Yes, sir. So in most of the patients that we get, we usually order for an ultrasound ourselves, because either there is obviously not a uniform way of reporting the thyroid findings. There is no thyroid scoring, or many a times we don't even get images of the thyroid scan that they've done. So we usually prefer getting it done, repeat in our institute.
So Dalpati sir, am I right in concluding that the kind of the radiology services are quite compromised in the rural setup, which is probably contradicting what you said a little earlier, that ultrasound is available at most places, or if I say even if it is available, the quality is quite may not be up to the highest of standards. So how do you like to conclude on the radiological services in the rural setup in support of surgeons?
Actually, if you take in Tamil Nadu and other southern states, even in our native, is a village. My place is a native place. In near that, in 5-6 kilometers, we have a good ultrasound. So only I told that it's available everywhere, but it may vary from various geographical areas and other places also. But having said that, ultrasound actually is, even if majority of the places must be available. If it is not available, then better to have an ultrasound at least by the physician or the surgeon who has seen in, or the general practitioner in a rural setup. If he sees an ultrasound, we can always emphasize them or uh, tell them to get at least a basic ultrasound in a nearby place where it is available, so that we can, the patient or the physician will be rest assured that the thing, there is no pointers towards malignancy, and so that we can follow it up. Even if it is a malignant, it is we know that thyroid cancer, even if it is malignant, it is not an emergency unless otherwise it is a anaplastic thyroid carcinoma or a lymphoma, like that. It's a you're having a thyroid nodule of 2 centimeter. Even if it is malignant, there is no urgency to operate. We can still evaluate in a higher center and ask them to refer also.
Okay, thank you, sir. I'll just throw the next question to Dr. Spandana. Assuming that an ultrasound has been done, and in this particular case also, ultrasound showed a spongiform nodule. What is your take on FNAC in this particular case where the ultrasound is suggestive of a spongiform nodule? And your opinion on the availability of a pathologist in rural setup and the quality of reporting that you have encountered from such a setup in your practice till date?
Thank you for the question, sir. Coming to the first question of what I would do in case of a spongiform nodule. Here it's a 15 nodule which is spongiform. Not all nodules warrant an FNAC, and this patient we can forego FNAC if we are quite confident with the ultrasound report.
Okay, and then the second part of the question, in your experience till date, are you satisfied with the kind of FNAC reports, patients coming from a rural background? I assume that as Dr. Dalpati sir said, there can be a lot of regional variations in the medical facility and also the literacy of the patient. What has been your experience at SGPGI till date?
So as we are a tertiary care center, we get patients who have already undergone FNAC, and we do get the reports, but many a times we see that they're not well reported, or they don't have the correct description which matches the diagnosis that they've given, or oftentimes it is non-diagnostic or it's inadequate. So cytopathology report is not always reliable if it is done in a rural setting or in a peripheral lab.
So what was your experience during your MS training, I think in Karnataka? Was it any difference from what you have been seeing at SGPGI, or you would just stick to the same statement that you just made?
Sir, I did my MS in Delhi, and there we would get an in-house FNAC because that was the primary stop where patient. We used to be the first stop where patients used to present to. So we would get an in-house FNAC and then proceed. And we would have pathologists in-house who would review who would report it, and we were very confident with our pathologists.
Okay, apologies for that mistake. I'll confront Bharat with all the wrong information that he has given me. Okay, so we'll just take it forward from that. As Dr. Spandana said, not all cases may actually require an FNAC, more so if it is a spongiform nodule. But even if we go by the availability of pathologist in a rural setup, or let's say, what is your assumption, Dr. Swarna? Do you think that a pathologist, or it's mandatory by the government to have a pathologist at its CHC, or it is not necessary, or normally a pathologist is not posted at a community health center, which caters to almost 80,000 to 1,20,000 population?
Sir, I'm not sure about the exact mandate, but we do not find trained cytopathologists at all places. That is something that I can say in confidence. The training that they get and the kind of experience that they have, it translates into the kind of smears that they produce and the quality of reporting that they do.
So, I didn't, not that I knew, but when looking at the data, less than 10% of the rural population actually has access to services of a pathologist.
Yes, sir.
So this is often something which may be compromised for all individuals, which may definitely have geographical variations, as Dalpati sir pointed out. Dalpati sir, how is it in Tamil Nadu?
Puranjan, actually getting ultrasound will not be a difficult job even in a rural setting. Maybe nearby we can, but getting a good pathologist is a problem. Even in anywhere, even in a city also, there are various inter-observer as well as inter-observer variations in pathology also. So majority of the rural setting, we might not find a good pathologist to report it. Even if it is report, we have to take it always with we need to review these reports or these pathology reports. So what I feel is we are good ultrasonography is better in a rural setting than to rely on FNACs.
I think that's a point well taken, and probably all of us would agree to that. Dr. Kushag, Do I take your consent for that to what Dalapati sir said, that it's better to rely on an ultrasound than an FNAC report when we are taking both of them into consideration?
Definitely at rural areas, sir, we would have a definitely much better in quantity as well in quality ultrasonography better than at as we don't have pathologists. As far I know, Indian Public Health Standards for PHC and CHC, they have only lab technicians. Only district hospital and above have pathologists. Pathologists are not posted at PHC and CHCs. So that is the take.
So as you rightly said, even in CHC is just a surgeon, pediatrician, gynecologist,
Yeah, emergency care. Yeah.
anesthetist. These are the only four specialists that are required around the corner. But what is even more disturbing, and if we look at that, looking at the 2023 data, there were only 913 surgeons in these PHCs and CHCs out of the 5,000 odd posts for surgeons, specialist surgeons. So that is almost less than 20% of all the surgical posts itself are filled. So the pathologists and the radiologists in the government setup is definitely going to be very compromised. Going by the data, and this is as late as 2023.
Okay.
Okay, and so just I would just like to throw this question to Ashwini. What is your take? Do you think our rural population has access to estimation of serum TSH, or even that is compromised, in your opinion?
So it will definitely be compromised. It is not very freely available at all places. But lot of at least PHCs are still offering. However, we do not know the reliability of that reporting either.
Dalpati sir, what's your take on the TSH, sir?
TSH actually we don't have in a PHC setup. In a district hospital, yes, all the district hospitals have TSH facilities. And now even suppose I don't know about many places, but in Tamil Nadu, every district has a medical college hospital. Every district, barring 2 or 3 districts. So we have 36 government medical colleges as well as some 40 private medical colleges. So all district hospitals are well equipped and it is connected. Health system is good, but at the same time, getting a good pathologist is always a problem. Again, I repeat, even in a city like Chennai, you must have a good pathologist to have a good FNAC, reliable FNAC as well as the histopathology.
So I would definitely second what sir is saying. Even a state like Uttar Pradesh now technically has, I cannot vouch for the quality, but a medical college in each and every district. And most of these colleges have actually been set up in the a little away from the district headquarters. So technically they are catering to this rural population where a lot of these tests are available. But even going by the data, if we look at access of TSS to the rural population, it is actually accessible to less than 1/3 of all the population. But definitely just putting a question, directing a question to perplexity as to, not to perplexity exactly, but I just try to look at the data as if we have a large collection center like even these private centers like Lal Pathology or so, it is heartening to see that almost 30% of the collection centers are actually located in rural centers or villages or smaller, what you call, tehsils.
Even sorry to interrupt, Kuranjan, even in rural places, even in near villages where we don't have a government facility, the private labs, small labs, they collect and send it to the district private labs. So where they do this TSH. If not in a government setup, in a private setup, it's available in a rural setting.
Sir, exactly, sir. Just trying to get to that. So that is a real silver lining that when it comes to blood tests, matlab most of a population has access. Financials may be a constraint. They do have access to these even specialized, many of these specialized tests, including TSH. So, sir, if I were to ask you, Dalpati sir, कि putting all these things now, a patient has been evaluated. What is your take? Like a thyroid surgery, assuming that this patient merits hemithyroidectomy, can be done in a setup rural setup, or it can be should be mandatory that they always refer to a higher center? Or what's your take on this, sir? If I can get my point across.
Actually, first we must be sure whether this nodule, which is a spongiform nodule, whether it warrants surgery first. If we are convinced that about the ultrasound and FNAC, then we can even follow this patient.
So
Though
for
we
a
are
spongiform nodule, we would have definitely for follow-up is a relevant strategy, and most of would have done it. I just said assuming that this patient,
assuming that if the
yeah.
even if the surgeon is competent enough, then he can do even in a district hospital or even in a taluk setup. If the because we need not actually centralize everything. We need not, in that case, we will not have time to operate all these patients. We must train them in the rural places, or we can teach them how to do a thyroidectomy, or they have been if a MS general surgeon, then he must be able to do a hemithyroidectomy at least with a safe approach.
Dr. Kushag, what's your take? Like straightforward, let's just say hemithyrectomy can be done at a CHC level or at nursing homes catering to the sub-district level or the level of tehsils, or they should ideally be referred to a higher center.
If there is a straightforward hemi, a qualified MS, if the surgeon has performed MS, and I think he's qualified enough to do a hemithyrectomy at a local center, be it a nursing home or at least a district hospital level.
So if I had just to fire another question to Dr. Kushag, currently you are involved with training of MS general surgery residents. Do you
Yes,
think someone passing out with MS, even from college like KGMU, they can safely perform hemithyrectomy?
yes, sir, they are
Honest
doing, sir.
answer.
Honest answer. Our students are doing in Sultanpur District Hospital, sir. They are
Okay.
posted in Sultanpur. Dr. Sukesh, I think you know him. He's doing at Sultanpur. He posted at Sultanpur and doing hemithyrectomies there, sir.
Okay.
Not
Fair
all,
enough.
but definitely who are confident they'll do.
Okay. Dr. Spandana, your take? Should a hemithyrectomy be should be done by a specialist endocrine surgeon or even a trained, like what's your take?
So, in my opinion, thyroid surgery is the safest in experienced hands, be it an endocrine surgeon at a tertiary referral center or a well trained general surgeon. As long as general surgeons are experienced with thyroid surgery, they exhibit competence and demonstrate adequate patient safety, they can safely perform straightforward cases.
And Dr. Rinal, your take?
So I would like to piggyback on what Dr. Spandana has said. I agree with her, but I also agree that you need to have backing in terms of a good anesthetist, and if in case there is any sort of complication, you would need some sort of backing to be able to manage that in a rural setup. So along with skill, there also needs to be a little basic administrative backup for a rural surgeon.
So Dr. Rinal, thank you for getting that point out. I'll come back to it again. Dr. Ashwini, your take?
So I think as long as the surgeon is competent enough and preoperatively, it looks like a straightforward heavy thyroidectomy, and if you have the facility and setup for it, it can definitely be done even in a rural setup, depending on the competency level of the surgeon.
Yeah, so as Dr. Rinal pointed out, my take on that would be apart from not the only the surgeon's competence, but also the anesthesia backup. So what our data has actually is less than 10 to 20% of the rural setup actually has access to general anesthesia. And even in the smaller nursing homes, at the rural level, or let's say at the taluka level, not more than 25% of them actually have general anesthesia backup. So it should be not only in the competence of the surgeon per se, but probably the supporting infrastructure. Dalpati sir, your take on that, and if you were to sum it up.
Yes, as we told, getting not only a good anesthetist, good backup, good nursing care, because the surgeon and the anesthetist will operate and go. The post-operative follow-up also matters in the immediate post-operative care. To look for any complications in the post-operative period also matters. Not only anesthesia, surgeon, you need a good team of nursing care in the post-operative period, because for a thyroidectomy, there can be a bleed in the post-operative period, which can happen also. So we need to be, the rural setup has to be in a way that it has to cater to all these needs. If the surgeon, anesthetist, and the team is well prepared and they are competent enough to do that, then they can do in a, it doesn't matter whether it's a rural setup or a district hospital or a taluk hospital.
So Dr. Dalpati has actually very beautifully summed it up. I would say it is not only with the competence of the surgeon, but it is a teamwork. Thydectomy is a teamwork, and unless the entire team setup is there with the adequate backup, a thydectomy or even let's say hemithyroidectomy should not be attempted in a rural setup unless the entire backup is there. So with this, I'll just go to the, we have already spoken about all this. Just we'll go to the next case. She is a 59-year-old lady with a swelling in anterior aspect of her neck for 7 to 8 years, gradually increasing in size. She does have palpitation, weight loss, and tremor for 2 months. No compressive features. Dr. Spanna, how do you proceed with this case in a rural setup?
So, I would finish my history taking and clinical examination. Since she has complaints of palpitation, weight loss, and tremors, she would probably be a case of hyperthyroidism. So I would go ahead with testing her TSH.
So,
And then,
Dr. Ashwini, TSH alone, or you'd also, if you're in a rural setup, you'd ask for the entire T3, T4, and everything?
Sir,
Yeah.
actually, if available, I would prefer a free T4 and total T3, because based on those levels, I can at least decide if I need to start on any anti-thyroid medications.
Okay. Dr. Kushag?
Yes, sir. So in a rural setup, I don't think free T4 would be available. So I would better rely on our T3, T4, total T3, T4, and TSH levels.
So, Dr. Rinal, the patients with hyperthyroidism and goiter, do you think they should be ideally referred or they can be managed in the rural setup?
So I think these patients would need to be referred to a higher setup because they need to be started on anti-thyroid drugs. And as endocrine surgeons, we are taught how to start on anti-thyroid drugs, but I don't think that's the case with rural surgeons. So they do have a general medicine counterpart there. They could probably refer to them, have the patient be started on anti-thyroid drugs, and then operate once the patient is euthyroid. But if they don't have that facility, then I think they should refer the patient to a higher center.
Dr. Kushag, your take?
Definitely, sir. A toxic goiter should be referred unless the surgeon is trained and experienced enough, which is less likely. So I would feel that since toxic goiter requires further workup and good anesthesia and team also, so such patient should be definitely referred to a higher center.
Sir, Dr. Dalpati, sir, your take?
Actually, we are not going to operate this patient. First line of management will be anesthesia and all. I don't think it's required. We need a good physician basically to treat. Put on whether they need to know whether the patient is a thyroiditis patient or a toxic goiter, Graves' disease or a toxic maternal goiter. In that case, then whether to start an anti-thyroid drugs or not. Most of the places, even in city places where the patient have cachetoxicosis or early phase of thyroiditis also, many of them are started on anti-thyroid drugs. So they need to differentiate whether it's a thyroiditis patient or a toxic goiter or a Graves or a toxic maternal goiter, because the treatment itself is differs, no? So if a good physician is there, then even at that place itself, they can start on anti-thyroid drugs. And maybe after starting an anti-thyroid drugs, if he is not confident enough, he can get a opinion from the district place or a higher center.
Third, probably second, Dalpati sir, ki diagnosis where even the matlab where we just have to depend upon the serological tests based on a TSH, T3, T4, or maybe even these antibodies. The primary diagnosis and the initiation can very well be attempted even in the rural setup. With all these collection centers mushrooming up, I think even the antibody tests are available. It's just that both are trained, probably a vigilant surgeon or a vigilant physician or a physician and a surgeon. They can definitely initiate or make a diagnosis or initiate. In case there are any lacunae, then only refer the patient. So that's my take on this. So in this particular patient, a pulse was 108. There were fine tremors of hands, warm skin, and there was a 4 into 4 centimeter firm nodule in a left lobe of thyroid which moves with deglutition, and the lower border is palpable. So Dalpati said, in such a scenario, a referral would be ideal, or
No, they can start antithyroid. If they're sure that it is a toxic nodule or a toxic nodule, they can very well start an antithyroid drugs. Why they want to refer? In that case, every patient has to be referred to a district or a tertiary care center.
okay, sir. So her thyroid function, her TSH was suppressed, and free T4 was raised, and ultrasound showed a left lobe, enlarged left lobe with homogeneous ecotexture, increased vascularity, and a hypoechoic nodule, almost 4 centimeters, no cervical lymphadenopathy. So, in such cases, Dr. Kushag, what is your take? And serological test alone, like antibodies or a thyroid scan, or both? Dr. Kushag, your take?
Yes, yes. In context of rural surgeons, I don't think so these tests would be available. But as per institutional policy, we definitely always go ahead with thyroid scans, always, sir. But in certain cases, we may require antibodies. So to see the level, the severity of hyperthyroidism and how it can be controlled medically.
So antibodies are more freely available, or these scans? What's your opinion?
I think both are freely available in a city setup, in a setup like Lucknow.
No, in
I
a
think
rural
both,
setup, I think it is it easier to get antibody level done, or may not be in context of this case, but or a thyroid scan?
So actually, we rely, as my practice, we rely more on thyroid scan. We don't do routinely antibodies. We only do on selective patients. So, but whenever we do, they are easily available. We don't find any difficulties in getting them done.
So Dr. Ashwini, not in context of this case alone. So when you're working up a case of hyperthyroidism, you would ideally, if you have access to both, you would order both, or based on the clinical scenario, or you would order you would just go for a thyroid scan, as Dr. Kushag said.
Sir, actually, based on the clinical history, if there is a history of long-standing goiter and recent history of hyperthyroidism, then I would prefer a thyroid scan. However, if I'm suspecting a Graves' disease, then I would order for antibodies.
Dr. Spandana, your take?
So if I have to choose one out of the two, I think I would go ahead with the thyroid scan than an antibody test at this time. Because on ultrasound, there is just a single nodule on the left side. So I
Okay,
would
in
go
this
with the
case.
thyroid scan.
Okay, acceptable in a general case of, let's say, routine hyperthyroidism. Let's say it was a case of clinically Graves' disease.
So yes, then I would definitely go ahead with the full panel of antibodies and a thyroid scan. Yes.
Dr. Rinal, your take?
So in the context of rural surgeons, I'm not sure if they would have the availability to do a scan or even an antibody. So I would suggest that for surgeons in the rural area to refer this to a higher center.
Okay. Dalpati sir, do you make your choice of scan and antibodies based on the clinical scenario, or you order both? Or what's your approach in such scenarios, sir? Let's forget the urban and the rural divide in your case for this question.
Actually, thyroid scan actually previously only it was done as a routine thing. Nowadays, actually, we don't have a nuclear physician in a government setup in the whole of Tamil Nadu. It's let me tell you, all the nuclear physicians are all in a private setup in Tamil Nadu. Let me tell you, so we don't even have a nuclear facility. That too, one person is in a contract even in Chennai. So if in Chennai it is the case, you can see in other places, other tier 1 city, tier 2 cities of Tamil Nadu or other places, we don't have a facility to do a nuclear scan. But if you see the antibody levels, that is freely available everywhere. As you said, lot of these labs are there in each taluk and district places. And ideally, we must, even in Madras Medical College, we don't rely on thyroid scans. Maybe institution to institution may differ. We don't do a thyroid scan unless otherwise warranted. And very rarely we do a thyroid scan to diagnose Graves' disease, because in that case we do a antibody levels as well as by clinical examination only we go. Very rarely we do a thyroid scan in these hyperthyroid patients. Maybe institution to institution differ, but we don't do that.
Sir, if I would like to, based on what we have spoken amongst ourselves, like the choice between an antibody and the thyroid scan, it would largely depend on the clinical scenario and the availability and our personal confidence. Can
Yes,
we end with that statement, sir?
yes.
So in this case, it was a solitary uptake only in one side. So in such a scenario, just quickly, such surgeries in case of hypothyroidism with an available anesthetist and maybe a competent surgeon, can we do these surgeries in a rural setup? Quickly, Dr. Kushagra.
If backup of good anesthetist is there and a comfortable OT atmosphere is there and surgeon is competent enough, then it would require hemithydectomy only. Then it can be done.
Safely.
Otherwise, if any of the thing is lacking, then the patient should straight away be referred to a certain higher level.
Okay. So with that, we'll go to the next case. So she was a 26-year-old lady with swelling in front of her neck, 2 years, gradually increasing palpitation, tremors, increased frequency of stools, weight loss for 3 years, no compressive features. And she had already been initiated on methimazole and Ciplar at her point of care or in the taluk level. And she reaches us and she has a pulse rate of 120, tremors, no eye signs, diffuse enlargement of thyroid, non-tender lower border palpable. So again here the thyroid functions was TSH was suppressed, T3, T4 raised, TRAB was 92, which is elevated, and the high resolution ultrasound bilateral bulky lobes heterogeneous and increased vascularity, and also scan showed diffused uptake. So just one single question: Graves, can the surgical management be attempted in a rural setup, or it is better to refer them? Quickly, Dr. Kushag.
I think they should be referred. If surgery is required for Graves, total thyroidectomy, if required, should be referred.
Dr. Ashwini.
So even I feel that the patient should be referred because surgery would be difficult. Post-operatively, the patient would have to be observed closely to look for any signs of thyroid storm. So it is better to refer the patient to a setup where all the facilities are available.
Dr. Spandana.
Sir, I agree with them. But if it is a small Graves and if the surgeon is competent, they have a good anesthetic backup, it can be done. But again, it's preferable to refer to a specialist.
Dr. Renel.
So I would suggest referring these patients because post-op management would be better in a tertiary care or referral center.
So all of us just assumed as surgeons ki we have to operate on this case and there is no other line of management. I'm great that all of us think alike. Dalpati sir, your take?
Actually, we can continue with anti-thyroid drugs first for at least 1 year or 1.5 years and see whether the patient go in for remission. If he doesn't go in for remission, we can then think about giving a radioiodine or if surgery is really required or not. If in case of surgery is required, then we can think of doing in a place where we have a good team, bearing whether it's a district hospital or a institutional setup. In the team, in the sense, anesthetist, as I told, anesthetist, surgeon, and as well as a good supportive staff. If the surgeon is competent enough, if surgery is warranted or indicated in this patient.
Yeah, so to sum it up, I think all of us would agree to Dalpati sir. Even my personal take has been, at least the patient from a rural background, I do attempt to continue them on medical management for as long as possible in case the smaller um, Graves' disease, assuming that at least 50% of them would not require any definitive management and can potentially avoid all the complications of surgery and maybe the few complications of even radioactive iodine. So, but needless to say, I think all of us are on one plane that surgery for Graves' disease can be challenging. Unless the entire team is competent enough, it should never be attempted at the rural setup or even at, let's say, CHC or a district level. There's a 17-year-old male swelling in front of her neck for 5 months, gradually progressing with sticky sensation in the throat, no compressive symptoms, no history suggestive of hypo or hyperthyroidism. There was a firm 2 into 2 centimeters nodule in the right lobe of thyroid, moves the deglutition, lower border palpable, and on clinical examination, there are multiple enlarged right cervical lymph nodes, the largest approximately 3 into 2 centimeters in the level 3 on the right side. So in a rural setup, Kushag, should they even such a clinical picture, should they even try to manage or just straight away refer?
Since if surgeon finds this, if there's a third nodule with a suspicion of malignancy, and ultrasound also suggests that there are lymph nodes and clinical palpation also.
Based on
Then
this
this
clinical examination alone, they have gotten to somebody in the nearby place, a physician or a surgeon. Should such cases where you're suspecting malignancy be managed there or ideally referred to higher centers?
at their center, I think only initial diagnostic workup can be done on ultrasound or a TSH level, or if FNC is available. And further, for further management, they should be referred.
So the diagnosis should be made at the first point of care.
Yeah,
Is
that
that
can
what
be
you're
tried,
saying?
sir. That can be
Okay,
tried.
Dr. Ashwini, your take?
I feel in such cases, it is better to extensively work up the patient in a preferably tertiary care center, rule out that there is no malignancy, and even if at that point observation is required, it can be done rather than missing a malignancy. Suppose FNAC turns out to be benign and the patient is never referred, we might miss a malignancy.
Dr. Spandana?
I agree with Dr. Ashwini. I think such patients should be referred. Trying to diagnose at a rural setting might also delay the diagnosis. So I think the patient can be referred to a specialist center where they can have a one-stop clinic for everything that the patient would require.
Dr. Renel?
So I feel if the surgeon is able to do justice to the disease and to the patient at with whatever things that they have in the rural setup, then they can operate on this patient. Surgeon is competent. Similarly, what I said before was if they have good anesthetic and administrative backing, they can operate. But preferably, this patient should be referred if they don't have that.
Is Dr. Ganesh connected?
So actually, he has gone to the ward. He got a call for a patient. He might join in now.
Acha, okay. I thought that I have committed a huge blunder and a mistake. Anyway, Dalpati sir, your take?
Yes, Kulu, I also agree with everyone. We need a specialized care for this patient. We must not miss the malignancy also. So better to have a one-stop referral to a tertiary care where everything is possible in a single place rather than actually the patient has to keep on running from one place to another and the facilities might not be there at one place also. So in this type of case, a little complicated one which need a specialized care need to be referred to a tertiary care center or at least a medical college hospital.
Well taken, sir, and thank you for that opinion. I think I would also are on the side of not her. I would suggest कि such patients are better referred, as someone also rightly pointed out कि God forbid we have an initial report of benign, the patient is reassured and sent back home. It can have severe consequences for the patient and their family.
Kulranjan,
Yes, sir.
Finish within couple of minutes.
Okay, so I'll just wind up with this. Just one question to everybody. When we're evaluating such patients, small nodule with bulky nodes or a hard nodule, do we routinely order for calcitonin in your practice or not? Dr. Kushag?
No, sir. We not routinely, sir.
Dr. Ashwini?
Sorry, I missed the question.
With a small hard thyroid nodule along with lymph nodes, all its, do you routinely order for calcitonin or?
Sir, in case of suspicion of malignancy, we have a low threshold for asking for calcitonin levels, so we
Dr.
use it
Fatima,
routinely.
your practice? Dr. Rinel?
No, sir, we wouldn't routinely send a calcitonin in these patients.
And Dr. Dalpati, sir, your take?
We also don't do routinely Kulranjan, but if there is some suspicion in an FNAC of medullary thyroid carcinoma, the possibility of medullary thyroid carcinoma is there, or any family history of medullary thyroid cancer there, then only we do routine calcitonin in the preoperative setting. Otherwise, for a blanket, all patients, just like TSH, we don't do serum calcitonin.
So I think that is actually what happens. But what literature says is almost most of the MTCs are actually missed preoperatively. Almost more than 50% of MTCs who present as an STN or STN with lymph nodes are actually missed. So it's just food for thought whether can we lower our threshold for ordering a serum calcitonin. But okay, it's nothing about being right and wrong. So this patient ultimately calcitonin was raised, and even the FNAC from the right lobe of thyroid is suggestive of medullary thyroid carcinomas, and FNAC of the cervical lymph node is positive for metastasis. So needless to say, it requires surgery, and all of us would agree that such a surgery should be done at specialist center or with a competent team. With this, I think I'll not proceed with the other cases, and I'll hand over the control to Bhargav sir for his views and conclusion.
Yeah, it's a very good stewardship, Kulranjan. So you have conducted the panel discussion very well. So to summarize, the concept of rural surgeon based on geography is superfluous, according to me, because even within big cities, there are pockets of rural setups and mindset exists, even in big cities. So it's a very blurred border between them. On the contrary, rural areas, some rural areas have very good access to advanced facilities. For example, I worked in rural setup from my MCH and did advanced cases in a rural setup. So it's like it also depends on the facilities, surgeon's confidence, other facilities which he has acquired. But definitely, ideally, a team approach and a balanced taking support of other specialists is always expected for patient's best outcome. So to summarize, effective management of solitary thyroid nodules relies on balanced evaluation, surveillance, and surgery. So growing insights into the nodule genetics, particularly mutations like BRAF, RAS, are enabling us for individualized approach of late. If not, manageable cases has to be referred to expert surgeon or endocrine surgeon. So finally, thank the organizers for giving me this opportunity, and I thank Sabha. Also, congratulate him for being professor of late. So with the final comments, I thank all of the members, and also with final comments from Dr. Kailash, you can finish this session and hand over to Sabha.
Okay, thank you. And Dr. Bhargav, it was nice. You very nicely summarized. And, thanks, Kulranjan, for bringing such nice cases. And our panelists who have given very pertinent and relevant answers to in the setup of rural surgeons. Though it is so far as thyroid is concerned, those straight cases can be done with a team in the peripheral level. But difficult cases like MTC and grapes should require a team concept and team management so as to avoid any morbidities and mortalities. But in which case, the surgeon has to be blamed unnecessarily. So, very carefully selected cases can be done in the rural level, but not much of heroism should be so far as concerned in thyroid is concerned. Those grapes. So, Kulanjan, thank you for bringing all these cases nicely. Thanks, Abba, for inviting us and giving us this opportunity for sharing our opinions. And thanks the experts, Dalapat sir, and everybody. Thank you very much.
Thank you, sir. And thank you all.
Thank you, sir.
And
Thank you, Kulranjan. Thank you, Bhargav. Thank you, Sabha. Thank you.
Thank you.
Thank you, sir.
For promoting us without interview.
You finished in time also. That's very good.
So thanks to
Abba
Bhargav.
is very happy. Okay. Thanks, everybody.
So we had a very happy panel, actually very happy panel discussion as usual by Kulranjan, and I thank Bhargav sir, Kailash sir, Talabadi sir, Dr. Spandana, Dr. Rinal, Dr. Ashwini, Dr. Kushagra, Dr. Ganesh, Dr. Mithun, who couldn't join, all of them for agreeing to be with Kulranjan's panel and then take things forward. Very interesting discussion. So coming to the next session, it's on management of differentiated thyroid cancer by Professor Anjali Mishra. She is operating a thyroid carcinoma patient, so she's not available at present. So we will play the endoscopic and robotic thyroidectomy video-based lecture by Professor Gyan Chand, sir. He is also away, so in like his recorded lecture is there, which we will play now. And Dr. Madhu, who is assistant professor under him for 8 months, she is available. So once any questions or anything, she will take. And to be rapporteurs for this session, we invite Professor Kamal Kataria and Professor Riju Menon. Riju was there. Dr. Riju? Oh, he is not. Dr. Riju Menon? Okay, if Dr. Riju is not there, Dr. Mahalashmi and Dr. Kushag, will you rapporteur this session? He is also gone. So no issues. Dr. Madhu is already there. Madhu is there. Dr. Kumari Madhu is our assistant professor. So she can rapporteur. So we will play. Dr. Madhu, you can. It's good. Are you people able to see the screen?
Yes, sir.
And voice you can increase.
Good evening, everyone. I would like thanks to clavicular approaches. Above-clavicular approaches are the facelift or retroauricular approach or transoral approach. The below-clavicular approach includes the areolar, axillary and rest approach, and bilateral rest and axillary approach. So the popular approaches are the affiliate approach, bilateral breast initial approach, and transferal approaches, and lateral facial approach. So how to select the cases? We select the benign lesion up to 6 centimeter, low risk malignancy, less than 2 centimeter, node negative, intrathyroidal capillary thyroid cancer in younger patients, or patient preference and demand for remote access thyroid surgery. So first is the endoscopic thyroid surgery. It is performed with conventional laparoscopic instrument with CO2 insufflation. So first is the axillary and breast approach, in which the patient is put into the supine position under general anesthesia. Axilla is open and 3 ports are marked, 2 into the axilla, 1 into the supraareolar region. So first port is start with the axillary mid port, 10 mm port, directing subcutaneously, directing towards the thyroid cartilage, and withdraw it, so make it tunnel into the subcutaneous vein, and then 5 mm port into the from the axilla towards the shoulder side, and another 10 mm port from the supraareolar region, focusing these 2 tunnels, and then start dissecting. So we can dissect with cold seizure, or we can use any energy devices, whether it is monopolar hook, or we can connect the monopolar cautery with the seizures, or we can use any ultrasonic device or bipolar devices for the raising of the flap. So flap is raised from supraesternal notch up to the thyroid cartilage, and laterally from one side of the sternocleidomastoid muscle up to the underside of the sternocleidomastoid muscles. So once the flap is raised, so we separate the sternocleidomastoid muscles with the stretch muscles. Then, like other procedures in which we go with the 2 head of the sternocleidomastoid muscles, here we separate and then open the sternoid muscles from the sternothyroid and separate it, and then open the sternothyroid muscles from the thyroid lobe. Here we have to be careful that not to injure any surface vessels from the thyroid tumor. Otherwise, chances of bleeding is there, and which is difficult to control. Then start dissecting from the lower pole and try to identify the recurrent laryngeal nerve. Once the nerve is identified, then we handle the inferior thyroid vessels. First is the inferior thyroid veins, which are large. We can handle with the direct energy devices, or we can use some hemostatic clips. Then start dissecting the inferior thyroid artery. Clip it, or we can directly cut with the energy devices. And further identify and keep in the region of the recurrent laryngeal nerve, and then start dissecting the isthmus. So do the isthmus first, and then mobilize the thyroid from lateral side and reaching up to the superior pole of the thyroid. The superior pole is handled either with the hemostatic clip or with directly using the energy devices to handle the superior thyroid vessels. Then finally dissected near the ligament of baby. Here we have to be careful not to injure the nerve due to the traction, and another is the insertion site. Clean the cavity, irrigate it, so any debris and blood is removed, and then put some surgical and close the strap muscles with 2, 3 like this. So put 2 or 3 interpret sutures, or you can put continuous micro sutures. So putting 2 approximately and giving the better cosmetic outcome rather than leaving disturbed muscles without closing it. So once you close the disturbed muscles, then put the bag inside and remove the specimen through central axillary port and put the drain into the cavity. So this is the post-operative outcome. You see after 6 months there is hardly visible any scar into the suprachoroidal region or into the axilla. Some examples of the cosmetic outcome of these patients: see the thyroid nodule and without nodule, thyroid nodule and after surgery, no scar, no nodule, another patient and totally scar-free neck. Second approach is the bilateral breast and injury approach, the BABA approach, in which the patient put into the supine position and arms are erected. So chance complication of the extension of the arms is not there. And then mark the skin both sides of the cleft, the two fingers will go parallel to the cleft. And 4 ports, 2 into the superior, 2 into the axilla, right will mark. Then you will get the apical saline solution over the chest wall and put in the R ports. So once the port is placed, then start dissecting. First over the chest wall area. By using any energy device, you can use the monopolar hook or the bipolar cautery or any ultrasound device. And then start dissecting over the neck. So disturbed muscle is separated once the flap is placed. Then separate the sternocleidomastoid muscles from the disturbed muscles. And once it is open, then as open surgical procedures, you open the midline and then start dissecting the nodule from lateral side. So we start dissecting from inferior to superior. Carefully. And then try to identify the parathyroid defect. So once you see the parathyroid, you can separate it, the parathyroid from the thyroid lobe. And once you separate it out, then try to identify the recurrent lesion. So once the recurrent lesion is visible, your job is easier. Then finally dissect lateral side towards the superior column. But once it is mobilized, then start dissecting from the trachea and do the stenotomy. So there are 2 approaches. Either you do the stenotomy directly, stenotomy first, or you can mobilize and identify the recurrent lesion first, and then try to, you will be more safe and confident in doing the stenotomy. So very close to the trachea, so careful not to insert any over the trachea. The trachea energy devices, the deficiency with the energy devices, and then mobilize from the lateral part, roll over the entire. Carefully dissect the recurrent lesion number K, and if you have no one, you can fluoride sense is important to dissect the nerve and preserve the nerve at the site of insertion and close the ligament, and then proceed further to the superior column. So reaching up to the superior column of the thyroid, finally processes and the digital devices and putting it back and take it out through one of the digital. So once the specimen is out, then you can check for and identify the distances, surface, and approximate the time by using the carpet or continuous 3D. They apply the presentation. And these are the outcomes. Start with it after 6 months. And this is the 6 week after surgery, hardly any scar is visible. And you can do the neck central neck dissection, the thyroid cancer, and also the lateral neck dissection is possible. It is biochemically cured, while stimulated thyroglobulin is only 0.2. And it is also oncologically complete surgery while doing the thyroid scan. The neck is totally scan negative. So that's why this surgery is biochemically complete and oncologically complete surgery. So cosmetic outcome is also excellent. You see the pre-op and post-op. There are some examples of pre-op and post-op. And hardly any scar is visible and excellent neck is there. The third approach is transoral approach, vestibular approach, in which the surgeon is operating from the head and side and is put into the supine position with extension over the neck, then putting the vestibular incision 2.5 centimeters into the lower lip. You can infiltrate that in the saline solution in the neck, and these are the 3 port positions. And then putting the port, 3 ports, 10 mm into the central and 5 mm the lateral side. And then start dissecting and raising the flap. So you can use the any energy device, as I told earlier, that energy device can be used to dissect the flap, raising the flap. So from one end of the sternocleidomastoid muscle to the other end of the sternocleidomastoid muscle to be raised. And once adequate flap is raised, then opening the midline as in with the previous procedures. But here the opening is from downside up. You are looking from upside down, so you have to be careful while opening the midline that not injure the trachea. And once you have separated out the strap muscles, then do the istomatry first in this case. So upside down, isthmus is bisected completely, and then intersecting from the medial side of the this strap muscles at the superior pole, close to the superior pole of the thyroid, and then take it out. And once it is dissected out, then try to open the space of the leaves and then pushing the thyroid down. So handling superior purposes individually. So it will help prevent the nerve. And once the adequate handling is completed, then it starts from upside down. Starting with the median and with the side. So first try to identify the recurrent lesion now. Sometimes it is visible at the site of insertion. In few cases it may not be visible, so you have to dissect laterally first and then try to rotate the thyroid to go from lateral to medial and try to identify the recurrent lesion. And once you identify the recurrent lesion, then you will work this easier and you proceed further. So lifting and dissecting the recurrent lesion now. And it is separated out, go to the inferior pole, thyroid. So you see the thyroid is mobilized, then again identify the vital structures, both parathyroids, superior parathyroid and inferior parathyroid, and recurrent lesion now. So once all 3 structures is identified, you are confident enough and then put it into the bag and take it out through the central 10 mm incision into the vestibular. To remove from the central part. And then again check for hemostasis. Everything there. So the close the mucosal chin side and put the pressure dressing over the chin. So that there is some cosmetic outcome of this transaction. This is the pre-operative and post-operative is no scar, good cosmetic outcome. And after 6 months, not scar, and the scar. So nothing is so it is totally scar-free thyroid. The limitation of these endoscopic procedures is selection of the patient required to select the small. It may take a long operation time. It may be more invasive than the routine conventional thyroid surgery procedures. Chances of obstruction of CO2 polarizations. Here, separate some special instrument is required. Learning curve and skill for laparoscopic procedure is needed, and extra cost is involved with no advantage in the complications taken. The complications are include conventional and usual complications like hypoparathyroidism, recurrent legendary seroma formation and hematoma. Some specific complications or unusual complications happens with these surgical procedures like hyperesthesia and paresthesia over the neck, thyroid formation at unusual site, emphysema formations, injury to the surrounding structures like internal jugular vein, trachea, carotid vessels, tracheotomy, vein injury, and traction injury to the brachial plexus, skin burn, blood perforation, and shoulder dislocation. So these are some unusual complications which is not common with the thyroid surgical procedures. Now come to the robotic thyroid surgery. So why robot is important? Like it is more popular than the conventional endoscopic procedures because of its magnifications, 3D visions, and robot endowrist, which have a no limit of the range of motions and precise dissection. So for these advantages, the robot is more become popular for thyroid surgery. So in this, you have to select some larger cases, well differentiated thyroid cancer, you can select. And there are several approaches for robotic thyroid surgery: midline approach, lateral approach, midline, the breast and axillary approach, natural orifice approach, the breast and axillary approach, the axillary breast approach, bilateral breast and axillary approach, sublingual approach, and vestibular approaches. In lateral approach, there is transaxillary approach and retroauricular approach. So similar as in the endoscopic procedures, there are almost similar procedures there. So in transexually, the 5 centimeter incision is given to the axilla and putting all 3 ports into the axilla, accommodate it, so it's not difficult to talking. So you have to be little bit experience is needed to talk all 3 instruments through the axilla. Second approach is the bilateral breast and axillary approach, in which similar as in the endoscopic procedures, as I told, all 4 ports have been placed, so 8 mm ports in the 2 into the supraalveolar, 2 into the axilla, and talking of the. So we have the winchet size or the winchet size still. So after docking the instruments, we start raising the flap and then opening the midline. So here, because of the flexibility of the instrument, you can go below up to the sternum notch, quite below, so you can handle the larger thyroid nodule. So we start dissecting from lower side up, especially close to the ligament of belly. You dissect it out. Especially the recurrent length. So it is very precise rather than in like an endoscopic thyroid surgery. The precision is little bit less, but here more precise. You can dissect more complete dissection of the thyroid, especially the malignancy, and you can take out the entire gland and the total thyroidectomy. the procedure is easier, same as in endoscopic thyroid surgery, but you see this, the dissection is very clear and you try to identify the left side, try to identify the parathyroids first and recurrent linear nerve. So inferior thyroid vessels has been handled with these procedures and try to identify the recurrent linear nerve in important visual identification of parathyroid and nerve. And you can use the neuromonitoring if you are not sure and you are beginner, so it will be easy to identify. But as you gain the experience, you know the site of recurrent linear nerve and you try to identify it. And finally, once you try to identify it, then you start dissecting the vessels. So sometimes it may take time to dissect the recurrent linear nerve identifications. And once you find out, you go and dissect close to the trachea. So you have to be careful while dissecting close to the trachea and close to the recurrent linear nerve, because these energy devices may causing harm to the patients and harm to the vital structures. So we have to preserve the vital structures, give parathyroid, and finally reach to the superior pole of the thyroid and take it out. In the bag, you may use endo bag, you can use indigenous bag, so lots of type of bags is there, and take it out through the monoflexual port, indicate the cavity in the saline, and then put in some hemostatic agent. You can use fibrillab, you can use Surgicel, or you cannot use anything, and then closing the midline. So approximation of the midline, I use 3 kilovital. So you can Stratafix, you can use the simple, you can use interrupted, you can use continuous. So continuous is the faster, so we use continuous switches. And finally close the midline. And then put in the drain. So once the drain is put it out, close the suture lines and port side, and then apply the pressure dressings. So here are some challenging cases. You see the large cases, hemothyroidectomy, can operate it very well. Some total thyroidectomy, large cases. Some neck dissection, bilateral lateral neck dissection is possible, and we did it in the cases. And this is a challenging case where the large thyroid nodule along with the large lymph node metastasis and patient demands for robotic thyroid surgery, and you see the large nodule in the lateral neck, and we operated it, and finally the patient is excellent outcome. Some retrostomal goiters we have operated. So recently operated one retrostomal goiters, which was usually contraindicated, but once you gain the experience, you can take it out through the robotic. Some other challenging cases, male patients with huge goiters, 200 grams, and female patients with huge goiters, total thyroidectomy, 227 grams, 10.5 centimeters. Some other challenging cases of 136 grams, and in male patients, challenging case 114 grams. Now come to the transoral robotic thyroid surgery. Here you same 3 ports position place and down the robot and raising the flap and then start dissecting. So once the flap is there, you can little bit more flap maybe dissect it out, and once it is dissected out, then it is opening the midline by using the hook, or you can use the harmonic or other bipolar energy devices, but the cost is the concern. So I used to use the minimum cost bearing robotic surgery. So the hook is the cheapest one, and so my surgery is very cheap for the robotic, but you can use the different devices, depends on the affordability of the patient. When the patient is affordable, you can use it. So start dissecting from the superior pole, try to identify the recurrent linear nerve. Sometimes you may find, sometimes you will not. So it depends on expertise and depends on the anatomical variation of these patients. So most of the time you can use the novelty to identification of the nerve, or which will identify the nerve by using these dissectors and try to identify. So sometimes it may take longer time also to identify the recurrent like the nerve. And once you identify, then your job is become easier and you dissect it out. So you preserve the parathyroid, preserve the recurrent like the nerve, and dissecting downwards. So if you are not able to find, you will start dissecting close to the thyroid superiorly and then go down. So you see the nerve is there, and once you find the nerve, your job is you become easier and you do the dissection away from the nerve. So there are some difficulty in some patients, especially close to the ligament of baby in malignancy. So you have to be careful while dissecting out, and then it is easier to dissect out from the lower side. So see the entire lobe is dissected out and then put into the bag, same as in endoscopy procedures, and take it out through the vestibular opening, put some surgical and approximate the midline as in the endoscopy procedures. So this is the closing, similar to few cosmetic outcome, post-operative and no scar at all. So you see this, you can handle the larger tumor size, more malignant tumor through this robotic approach. So the total experience we have for endoscopic and robotic thyroid surgery is 551. I have operated all different approaches like axillary test approach, bilateral breast and executive approach, and transvestibular approach, and also the robotic thyroidectomy all approaches. So in summary, the endoscopic and robotic thyroidectomy is safe and effective in selected group of patients. If you adhere to the strict selection criteria, can help to ensure a safe outcome and excellent cosmetic outcome and good quality of life by all aesthetic approaches. Thank you very much for giving me the opportunity. Thank you so much.
Thank you, Gyan sir, for that wonderful lecture. He was away to US, and on top of it, he took time to record and send. With us here, Dr. Kumari Madhu, who's an assistant professor. She has been with Gyan sir for the last 8 months. She will give just her view about endoscopic and robotic thyroid surgery and her experience in the last 8 months for 2 to 3 minutes. Then we go to the next session.
Thank you, Sabha sir. And this is actually, I can say, this is an eye-opening conference for rural surgeons. And this is not for them, it's not far away for rural surgeons, endoscopic or robotic surgery. If one devoted rural surgeon can have a great interest in endoscopic thyroid surgery, they can train himself and can perform these surgeries at their center if they have available instruments and all. And I can say robotic and endoscopic surgery for a small thyroid nodule, because most of the patients are staying in the rural areas and they have to travel so far to come to our places for the surgery. So if rural surgeons can take this to their center, to their places in the rural areas, this will be a great thing for the patients who are staying far away and interested patients for the scarless surgery. And after a learning period, it is possible for them also. Coming to a small, I am just adding a few points for the endoscopic and robotic. Endoscopic surgery is actually remote access surgery, thyroid surgery. It is not minimal invasive. Most of them are confused because of these are the minimal invasive surgeries. No, it is not minimal invasive. It is actually remote access surgery, just to avoid the scar over the neck, because neck is the part of our face and it is visible all the time. So to avoid the scar over the neck, it can be deviated away from the neck and can be performed the surgery, can be done in this situation. And in the robotic thyroid surgery, although currently the cost of robot is high and robotic surgery is a little higher in comparison to open and endoscopic, but I'm hoping for the best. Robot can be available at lower prices in future, and then it will be available at different centers, and then its cost going to be down. And in that situations, we all will see the importance of robot. It gives the stability and quality of camera and articulated arm, and also the surgeon's ergonomic. This is surgeon's ergonomic is what is the most neglected thing in the today era. So including the surgeon ergonomics and advanced camera, that provides the much confidence to the surgeon who is operating in protecting the recurrent laryngeal nerve and parathyroid, and also who can perform the larger thyroid goiter with confidence. Thank you. Thank you, sir.
Thank you, Madhu. And any young surgeon like Dr. Madhu, who's been doing this procedure with Professor Gyan, sir, they should take leave out and they should also start doing. Now, because Professor Anjali Mishra ma'am is still operating, I request the president of IAES, Professor Gaurav Agarwal, sir, to take over, and Professor Pooja Ramakant ma'am. Both of them are there. So first they will start with, because panelists have to join at 7. First will be that interesting adrenal cases, and then we will have the panel discussion between 7 to 8. Over to you, sir and ma'am.
Thank you, Dr. Sabaratnam. This is a good initiative by the Association of Rural Surgeons of India to involve the Indian Association of Endocrine Surgeons for a combined academic activity. And so, on behalf of the IES, I welcome the participants. I see majority are endocrine surgeons only, but even others who may be listening to it, you are most welcome. And during this session, we intend to have one session on interesting adrenal cases, which will be presented by team from KGMU and Dr. Pooja Ramakant. And then later, we will have a panel discussion on management of primary hyperparathyroidism. Over to Dr. Pooja.
Thank you, Gaurav sir. Thank you, Dr. Sabha, for involving IAS along with ASRI joint session. And we understand that we have to interpret and see how things are happening in the rural areas and plan things accordingly. So I invite Dr. Bharat from KGMU team to present an interesting case on adrenal and the challenges and how we managed it. And following him, Dr. Prashant will be showing another scenario where we had a lot of other issues also. So I think these are very relevant day-to-day issues which we all deal with, but good to learn from these cases. So Dr. Bharat.
Yes.
Thank you.
Is my screen visible, ma'am?
Yes, now it's visible.
Good evening, everyone. I'm Dr. Bharat from KGMU, Senior Resident. I thank Dr. Sabaratnam sir for giving me an opportunity to present in this. Today we'll be seeing the important case. She was a 61-year-old female who presented to us with multiple swellings all over her body since last 10 years, which was increasing in number and frequency. She also had a complaint of intermittent episodes of epigastric pain with bloating sensation for 1 year. She also had complaints of intermittent episodes of palpitations for 1 year. There was no history of nausea, vomiting, or altered bowel or bladder habits. There was no classical history of pheochromocytoma such as episodic headache, sweating. On examination, she had multiple caféolate spots. Her lymph nodules were positive. She was normotensive during her admission. MRI, we got her MRI done, so that MRI was suggestive of auricular plexiform neurofibroma in the region of fifth cranial nerve. So she was started on alpha blockade and was planned for surgery in 2021. She had a default of 3 years due to her personal reason. During this period, she had stopped alpha blockers. So she was readmitted in 2024. Her complaints remain mostly were limited to abdominal pain and abdominal distension. So we got a hormonal evaluation done. Hormonal evaluation, as we can see, a baseline cortisol level was normal and ONDST was suppressed. Her urinary metanephrine and normetanephrine levels were more than 5 or 6 times the normal reference range. That was 3,700 and 2,493 respectively. So here in this CT scan, we can see that in the region of right adrenal, her mass, which was 49 cross 40 planes were essentially normal with the surrounding structures. There was no significant increase in the size. Also, she had a left uterine vesico-uterine pouch mass, which was measuring 81 cross 79 which was irregular, and it had mixed hypodense along with hyperdense areas. So on cystoscopy, we got a cystoscopy done. The cystoscopy showed a bulge in the anterior wall without any intraluminal growth extending into the urinary bladder. And a guided coronidal biopsy was done from this tumor, which showed a gastrointestinal stromal tumor. So along with this, she had a jejunal mass, so which was 22 cross 18 which was hypoechoic lesion present in the left hypochondrium. So the most important feature of this patient, she had a pulmonary bulla, which you can see here. This is connecting pulmonary. This is the large pulmonary bulla, which measured somewhere around 7 cross 6 centimeter. This was connecting with the trachea. So she had a tracheobullous fistula. This was a major anesthetic concern for the both for our team and anesthesia team. So the PET CT, we got a PET CT done to rule out any other metastasis or any other primary cancerous lesion. So this showed there was no uptake in right adrenal region, and there was a very patchy uptake in the vesico-uterine pouch and also in the jejunal region. So we admitted the patient. She was started on alpha blockade. Prozusine 2.5 mg BD was given. BP supine standing was taken. There was no orthostatic hypotension. So beta blockers were started prior to surgery. She underwent surgery. We did an exploratory laparotomy with right adrenalectomy with resection of jejunal gist with side-to-side anastomosis. So her operative findings showed a pheochromocytoma in the right adrenal region measuring 5 cross 4 cross 3 centimeter. Also, along with this, there was a 12 cross 12 centimeter exophytic gist arising from the intestine at 150 centimeter from the DJ flexure. Also, along with this, there was a 2 cross 2 centimeter exophytic gist at the DJ flexure. So perioperatively, the patient recovered well. She needed no ICD insertion. The bulla didn't rupture, thankfully, and the patient got discharged after 1 week. So her post-op histopathology, her sparse score was 3, which was benign. The gist was spindle cell type. It had a mitosis of 5 per 50 high power field. There was no necrosis, and it was a low-grade gastrointestinal stromal tumor. So this was kept on follow-up. So the main challenge in this management of this patient was she was a high-risk surgical candidate. The pulmonary bulla could have ruptured anytime and would cause pneumothorax. Also, simultaneously coexisting gist along with pheochromocytoma and the jejunal mass, she should have been considered for the syndromic management. So, coming to the review of literature, neurofibromatosis 1 is associated with neurofibroma in 0.1 to 5% of the patient. It's usually benign and it's unilateral. This may cause anesthetic problems. So the NF1 associated GIST incidence is 3 to 8%. So it's usually a sporadic GIST, which is multiple, non-KIT mutated, and oftenly it is found in jejunum. So these are usually KIT or PDGRFA wild type. They show very poor response to tyrosine kinase inhibitors. So surgical resection is the mainstay. So occurrence of vesicouterine pouch is just is extremely rare. So we should have directly considered the patient for directly surgery. So these are all the features which are associated with neurofibromatosis, NF1 patient. So we can see here our patient had a GIST pheochromocytoma, plexiform neurofibroma, capillate macules. So these all features were present in our patient.
So thank you, Dr. Bharat, for putting this patient on this platform. We had a lot of challenges, as you said. The bulle, we didn't know whether to put the ICD first prophylactically as discussions with the anesthetist, or to wait for bulla to rupture and then to put the ICD. And then other issue was how to plan surgery for these lesions together. Should we give a single midline incision, or should we plan laparoscopically? But is laparoscopy safe with bulle? That was an issue. She was very cachexic, malnourished lady. So many issues were there. Or should we give two incisions, subcostal one and Fanelstein incision for the lower jejunal mass in the chest and pelvic mass also. So a lot of confusions were there. But finally, we got away with the midline single incision, and with the gastrosurgeons who helped us with the stapled resection anastomosis of the bowel. So that way, I think a lot of planning and roadmap for such patients have to be done. And in the follow-up, she has come, I think every once in 3 or 4 months, she comes in emergency sort of a crisis as a bulle trouble, and she has lung interstitial lung disease. And every time she comes to us and then gets transferred to pulmonary medicine, respiratory medicine department, and they manage her symptomatically. So her now concern is only the lung lesions. Otherwise, rest from endocrine part, she is doing well. For GIST also, one opinion was to give imatinib, downstage it and then plan. But she couldn't afford imatinib, so because of cost issues, we didn't give her that option. So that option is also available when somebody has GIST. And then now I'm open to any comments or concerns or any questions from any of the audience or people who are listening to us.
Hello, ma'am. Actually, there are no comments as of now in YouTube or in this one. So, like, if I want, like, you said imatinib, what is the usual dose of imatinib for GIST, and how it is, how much is tolerable for Indian patients? We also had a patient who couldn't tolerate, and this patient had an
Yeah, you're right,
lipoma
Sabha.
with
It is
GIST.
toxic.
I have.
Yeah, it is toxic. You have tried in some patient?
Hello.
So dose is around 400 milligrams, but then issue was only the tolerability plus the cost issues. So this patient was very poor, and we had to help her with the financial part for the even for this surgery.
Yes, ma'am. That is what, because as you rightly pointed out, tolerability in this one, and when there is a financial issue also, then it becomes very difficult to manage such complicated patients. Actually.
Right. But it's good that means she did well, and we didn't had any morbidities with her. So I think that is also a challenge which we learn, and as surgeons, we become more confident in managing such patients. And
Yes,
that is a real
that is a
world
very
scenario. We don't
important
get
point, madam, as
ideal
you said.
nutritionally rich patients. Huh?
Yeah, and whenever they are saying like we are a capital city, but most of the patients in KGMU as well as majority like at least 60% or I can say 70% of patients in even SGPJ are patients from rural background. Like they come
Right.
so and most importantly like met a patient somewhere some time back in when I went to a village near a village 100 kilometers from Lucknow. They do not have even bus facility. So we have to, when not this patient, I'm saying whenever we call any patient for any follow up and things, we should be thinking many times before whether we warrant these patients to come. And as Bharat has nicely presented, this is a very, very interesting adrenal case. So I really appreciate your time for that.
Thank you, sir.
Thank you, Dr. Bharat. So now we invite Dr. Prashant, who shall be presenting another scenario and where we had problems with the pathology and decision making. So we will see how he explains and shows. Thank you.
Am I audible?
Yes, yes, we are audible.
Good evening, all. So I will be presenting a case on malignant pheochromocytoma. So he was a 40-year-old gentleman with complaints of intermittent episodes of headache, palpitation, and sweating. He had no history of loss of consciousness, seizures, of weakness of limbs. He had history of pain. He had no history of pain abdomen or vomiting. He had history of left-sided facial palsy 6 years back, which was associated with fever and was managed conservatively. During that point of time, he was evaluated by a physician and was diagnosed to be hypertensive and was started on antihypertensive drugs. He is a known case of HIV on antiretroviral treatment since 2020. He is a known case of chronic kidney disease. He had no family history of sudden death in the family members, but one of his brother had died at the age of 48 years due to CKD. On examination, he had no pallor, icterus, cyanosis, clubbing, or lymphadenopathy, no striae or bruising, no neurocutaneous markers were present. On per abdomen examination, no tenderness or guarding or rigidity was present, no organomegaly was present, all hernial orifices were normal. Systemic examination was essentially normal. On hormonal evaluation, his baseline serum cortisol was within normal limits. His ONDST was also suppressed. And his 24-hour urinary metanephrine and non-metanephrines were also within normal limits. They were repeated 2 times, and both the times his metanephrines and non-metanephrines were within normal limits. His serum aldosterone and plasma renin level also were within normal limits. Whole body PET CT was done, which showed a 8.1 cross 6.1 cross 7.1 centimeter lesion with a SUV max of 21.8, abutting the upper pole of kidney and adjacent level medial to the aorta. USG abdomen was done, which showed a well-defined, delineated, heterogeneous, predominantly hypoechoic lesion measuring 7 cross 6 centimeter at the left adrenal region, likely left adrenal neoplasm. A CE-MRI was done before the surgery, which showed a 67 cross 57 mm altered visual intensity lesion in the left suprarenal region. The lesion showed differential restriction with patchy non-restricting areas. Anteromedially, abdominal aorta was in close proximity, but there was no abutment. Posteriormedially, it was abutting the crus of diaphragm with maintained fat planes, and anteriorly, it was abutting the tail and body of pancreas with maintained fat planes. Uh, so the patient had underwent a guided core needle biopsy elsewhere, which was suggestive of poorly differentiated carcinoma. And when we reviewed the biopsy and applied IHC, it was positive for synaptophysin and chromogranin. Hence, a diagnosis of pheochromocytoma was made. So we went ahead with surgery, and the patient underwent left adrenalectomy. Uh, a left adrenal mass of size 6 cross 6 cross 5 centimeter was present intraoperatively. Perioperative period was uneventful, and the patient was discharged on post-operatively. His blood pressure did not come back to come back to normal completely. So he was discharged on nifedipine 20 mg OD. His histopathology was post-operative histopathology showed a well encapsulated adrenal gland tissue infiltrated by neuroendocrine neoplasm deposited in lobules, nests, or clusters. The lobules were separated by fibrous septa forming the gel balance pattern. Individual tumor cells were pleomorphic, round to oval, hyperchromatic nuclei, coarse chromatin, and scant cytoplasm. Nuclear molding was also evident. He had a PAS score of 8, he had a PAS score of 8, and a diagnosis of malignant pheochromocytoma was made. So, to define malignant pheochromocytoma refers to pheochromocytomas that metastasizes where chromaffin tissue are normally absent, such as bone, liver, lungs, or lymph nodes. Histologically, there is no reliable feature that distinguishes malignant from benign tumors. Only the presence of metastasis confirms malignant pheochromocytoma. So overall incidence of pheochromocytoma is 0.8 to 1 per 1 lakh persons per year. Malignant cases among pheochromocytomas range up to 5 to 26% of the cases. If we compare adrenal versus extraadrenal or paragangliomas, malignancy is more frequent in extraadrenal paragangliomas than in adrenal pheochromocytomas. There is a higher risk in SDHB mutation for malignant transformation. So the key factors for malignancy are large tumor size, more than 5 centimeter, extraadrenal location, SDHB gene mutation, high non-epinephrine secreting phenotype, and high Ki67 index or high PAS score.
So thank you, Prashant, for highlighting this case. This we had different biopsies, and then pathology is very important for such. And other thing from our side, planning for the surgery. And then other thing is adjuvant management for this patient. As a pathologist and malignant, so should we do some DOTA scan or should we just keep on close follow-up? I think adjuvant planning is a question for him. I think we offered him, but he had no money and he didn't wanted to do a scan. So we have kept it on close follow-up, but that's an issue. I think Dr. Shashi Molly has raised an issue about the alpha blockade. So he was planned
The patient
given, yeah.
was started on alpha blockade before the surgery.
Hmm. So Dr. Chanchal is there from pathology side. Chanchal, can you comment? Can you say like malignant pheo, or you can just say pheochromocytoma with a PAS score high?
Actually, the PAS scoring system is not a definitive criteria, but it gives an indication that it is likely to be malignant or it is probably benign like that. The score cutoff is 4. If it is more than 4, then it goes in favor of a more aggressive disease. And this patient, I remember, the past scoring score was more than 6 in this patient.
Yes.
So, although metastasis is only the criteria to differentiate a benign from malignant, but considering the score, this case has a higher probability of being a malignant case and having an aggressive outcome.
So as pathologists, we can say malignant pheochromocytoma. Means that was the thing.
Yes, the word probably is added, probably benign,
okay.
probably malignant. So in this, with the present score, it will be probably malignant.
Okay, sure. Thank you, Ranjan. So Dr. Vivek sir has asked, what adjuvant treatment will you plan? So for him, plan was, means ideal plan is if we can do a full body functional imaging like DOTA scan or something, Nuratech, and then if there's some uptake, then to plan for lutetium therapy or some ablation, or if we do MIG scan, positive MIG ablation, something like that can be done for malignant pheochromocytoma with metastasis. We don't know he has some asymptomatic metastasis right now or not. But as patient didn't had money, and so we have told, okay, come after 3 months, we'll do the urinary collection again, metanephritis. So if there is some metastatic focus that may be elevated, so then we have to chase and look for metastatic foci. I think that is the only adjuvant plan we can have, because I think maybe he doesn't need radiation therapy, so chemotherapy doesn't have much role. So I think only nuclear medicine therapies have some adjuvant role. So any other questions or comments from other people? Dr. Sabha, should we wrap up?
Yes, ma'am. Thank you, ma'am. No questions from YouTube viewers also. So thank you again. And I request now for the panel discussion on primary hyperparathyroidism, which moderator will be Professor Gaurav Agarwal, sir. And then we have panelist Professor Pooja Ramakant, ma'am, Dr. Vivek Agarwal, Dr. Sapna Botra, Dr. Ramani Tripathi, Dr. Ramya V, Dr. Shivendra Verma, and Dr. Chanchal Rana. Over to Professor Gaurav, sir, for this panel discussion. And the panel discussion shall commence now at 7:03 p.m. and it can run until 8 p.m. Madam is still operating and she is not able to present today.
Okay, thank you very much. Can Dr. Prusti, yeah, he has stopped sharing his slides. I will start slide share from my end. So we have between 40 and 60 minutes, depending on how soon can Dr. Anjali Mishra join. And firstly, thank you, Ratnam, once again for asking the IAS to partner with the ASRI for this session. And I welcome all the panelists. We have some very eminent endocrine surgeons, Dr. Vivek Agarwal, Dr. Pooja Ramakant, Dr. Sapna Botra, Dr. Navneet Tripathi, and Dr. Ramya. And we also have an endocrinologist joining us, Dr. Shivendra Verma, and Dr. Chanchal Rana, who's professor of pathology at KGMU. So we have all the expertise we desire discussing management of primary hyperparathyroidism. Considering this discussion is primarily aimed at surgeons practicing in rural settings and for trainees in surgery, we should keep the discussion quite basic and of utility to everybody who has connected to this Zoom session today. So let me start by saying that primary hyperparathyroidism has evolved a lot from the overtly symptomatic disease with bone stones psychic moans or abdominal groans and psychic overtones, we now are facing majority of our patients have either minimal symptoms or no symptoms at all. Or maybe not majority, but at least a sizable proportion. And this has been a phenomenon seen a few years ago, a few decades ago in the Western countries, and we are now witnessing this. So the picture is changing not only in certain centers, but majority of centers in the country. So let me start by asking the panelists, what proportion of patients in your own experience you think are asymptomatic or minimally symptomatic? Can we start with Dr. Vivek Agrawal?
Good evening, everybody. Thank you, Dr. Gaurav. So in my own practice, I would say the percentage of asymptomatic hyperpara has been to a tune of 25 to 30%. And this progress is being seen to a tune of 1 to 2% every year since I've started practicing. So it's been like last 2 decades, and this is probably the way it is moving forward.
Great. So it's falling quite in line with the expectations. Dr. Pooja?
Yes, sir.
What proportion of your patients currently are asymptomatic or minimally symptomatic?
So unfortunately, majority 99% are symptomatic with advanced disease and end organ damages. Very rarely we see asymptomatic.
Okay, so let's hear from the corporate surgeon from Lucknow, Dr. Navneet.
Good evening, everyone. So in my practice, I guess my patients to the tune of 15 to 20% patients are minimally symptomatic, especially with the advent of these health packages, which we see in more in corporate settings and all these profiles.
Okay, so there is a stark contrast between a public hospital in Lucknow to private. Dr. Ramya?
Sir, on contrary, in my practice, what I'm seeing is majority of the patients are asymptomatic. So a month, I would operate 2 to 3 cases, and most of them are detected through blood tests. So yeah, so very till now, I think I have only seen 2 or 3 patients who have overt symptoms, but if we test them, they have subclinical other features like osteoporosis, etc.
All right. And Dr. Sapna, what's your view?
Good evening, everyone. Sir, I would like to mention here that I think majority of the corporate patients, I would say, are asymptomatic or minimally asymptomatic, around in the range of, I would say, 10 to 20%. But if we consider the patients who are referred to us after being diagnosed elsewhere, then the percentage would increase. I think in that case, 50 to 60% of the patients would be symptomatic if we include them. Yes, sir. Because they are mostly referred and diagnosed elsewhere.
Dr. Shivendra, as endocrinologist, maybe you are seeing a wider spectrum of patients, including such who do not require surgery or perhaps are not referred for surgery. What do you think?
Yes, sir. Good evening, sir. Yes, sir, quite correct, because we get a lot of referrals from patients have routine investigation showing calcium. And we also do many a times calcium test on patients based on other comorbidities. Like today also one patient admitted for insulinoma. Unfortunately, he has concomitant high calcium, and which we do as part of the protocol for syndromic association. So I would say 40 to 50% come with the asymptomatic. However, once the referral is from the nephro or from your side also, most of the cases are actually symptomatic. They come up with some sort of histories.
Yeah, so in our annual audits, currently around 10 to 12%, 10, 15% are asymptomatic. So let's move on. Diagnosis of primary hyperparathyroidism is essentially based on biochemistry. I'll request all the panelists to raise their hands and interject whenever you want to make any point. But is there any contrary view to this? Is the diagnosis based on anything other than biochemistry, or can it be based on other than anything than than biochemistry? Clinical histology, imaging, or cytology. I hope none of you have that view. So we can then go ahead with discussing what is the minimum set of investigations or biochemical investigations you would like to do. How about starting with Dr. Pooja? Uh, what's the first set of biochemical investigations you would ask for in a patient who is suspected to be having primary hyperparathyroidism?
So we'll start with doing the calcium, then serum albumin, phosphorus, PTH, vitamin D, alkaline phosphatase. So, and then 24-hour urinary calcium and creatinine if available. Good to have that value also.
Great. Dr. Vivek, anything you would like to add?
I think Pooja has given a complete list of investigations required to confirm a biochemical diagnosis. So nothing much to add.
Okay, Dr. Chanchal, I know, I mean, you get involved only much later once the diagnosis has been established by and large. But is there anything you would like to remind us clinicians?
Yes, I would like to add two more tests in this panel. One is instead of a serum PTH, however, it is not everywhere available, but the analysis of an intact PTH will be more useful and informative because it specifically analyzes the complete hormone, which is actually the biologically active form of PTH. And secondly, apart from the corrected serum total calcium, ionized calcium, I think, would give a better overview of the calcium level in the patient.
Yeah, I agree. But regarding the PTH, Dr. Shivendra, isn't it that we, as a routine, almost all labs now only assay the intact PTH, the whole 84 amino acid PTH rather than any N-terminal or C-terminal now?
Sir, currently, most of the labs, even the commercial ones, are doing the latest generation intact PTHSs. However, I would just like to point out one patient of mine in which the PTH came very low. So we have to disseminate this information that proper temperature control for before sending the samples is also very important, because I've seen one case in which PTH was very low but clinical suspicion was high. But most of the labs are now doing intact PTH, and smaller labs don't do, they actually send to the other larger labs. And yeah, and phosphorus, one more important thing is it should be done in the fasting state, not in the postprandial, that it can be falsely low if it is done after meals. So these are the two important things that I
Yeah, I
would like.
think this is a great point. Any biochemical test, unless done in ideal conditions, collection, assay, everything, you would be looking at some false positives and negatives. Okay, so we are now looking at not just a classical symptomatic or asymptomatic primary hyperparathyroidism. We also have a set of patients who are not necessarily having the classical biochemical picture, and certain patients who have familial disease, something which Dr. Shivain was discussing earlier. So we need to be cognizant of the fact that, of course, majority would have the classical biochemical picture. Some may not necessarily belong to this. So let me now use one of the patients, actual patients, to discuss some more aspects of management of primary hyperparathyroidism. This was a young patient, female, 33 years, who presented with knee pain and progressive limb weakness. And actually, she has had this for quite some time. And she had kyphosis for, again, almost close to a decade. And then on evaluation now, so many years after starting having these symptoms, she was found to be having hypercalcemia and hyperparathyroidism. So, what is the next correct step in such a patient? Dr. Ramya? Would you like to take us forward with managing such a patient?
Sir, yes. So in this patient, I would like to know the other values as well, like the serum phosphorus and what was the vitamin D, and so then of course localization studies like the ultrasound, and if we are in a resource constrained setup, if we are confident with ultrasound, we can stop there if we have a correct biochemical
Okay, we'll
diagnosis.
come to the localization a little later. But yes, you, as you said, so mere serum calcium and PTH is not sufficient. What must be also looked at is the phosphorus level. We
Creatinine.
expect it to be low, normal, or no, or suppressed, and also creatinine, 25 hydroxyvitamin D, minimum of this. And then once the biochemical diagnosis has been established beyond doubt, that is when you start considering localization studies and not the other way around. I mean, I like to take this opportunity to remind all the PGs and the surgeons in training that localization studies are not to be done before establishing biochemical diagnosis beyond doubt. So then, what parathyroid localization studies would you like to do, Dr. Sapna, in this patient who has so far never been treated for primary hyperparathyroidism? Or in other words, if she has an indication for surgery, this will be her primary surgery.
Sir, if you think, if we consider that we are doing it for a rural setting, I think the first investigation available would be a mere sonography. But it would be very difficult to find an experienced radiologist who can see an parathyroid on a sonography at the rural setting. But first, I would like to get an ultrasound scan. And the second would be a nuclear scan, that would be a Sestami B SPECT CT if available.
Yeah, I agree that though we are talking of practice in the rural scenario, these are patients who would have to be referred to
Yes.
invest in appropriate centers and not be managed unless for some reason, or we are lucky that some center have all these expertise and facilities available. But I think it could be worth reiterating that patients who have a diagnosis of hyperparathyroidism or suspicion of hyperparathyroidism are best referred to an expert center, expert endocrinologist, endocrine surgeon, rather than being managed at a peripheral level. So, I mean, just to remind everyone, the guidelines, the American Association of Endocrine Surgeons, American College of Endocrinology, they say that an experienced endocrinologist or surgeon would not only evaluate, but they would ascertain which type of imaging to use based on the knowledge of their region's imaging capabilities. Now, not every center would have great quality nuclear scans or imaging with CT, but more often than not, majority of the centers would have a good quality ultrasound. And for that matter, experienced surgeons themselves or endocrinologists themselves can do focused ultrasounds to detect a parathyroid lesion. What is recommended, and again worth reminding everyone, is preoperative parathyroid FNAB is not recommended except in unusual or difficult cases and should be performed if parathyroid carcinoma is should not be performed if parathyroid carcinoma is suspected. And if in case you are doing FNA, it's parathyroid washout, which is of greater utility. But as Dr. Sapna said, the first line imaging stays or continues to be a well-performed high-resolution ultrasonography and NIBI scan. Of course, there can be other options, 4D CT, and we'll come to those a little later, and MRI and venous sampling. But these should not be considered as first line. Any views on or any views on what are the strengths of centers in India when it comes to preoperative localization? Any of the panelists would like to take up this? Maybe Dr. Shivain?
Sir, in India, I think most of the center are still practicing this conventional practice of ultrasound thyroid parathyroid for along with maybe. And if the lesion is concordant, then we are pretty sure. And I think I'm here for last 1 year, and I work there in Vellore also. So the requirement of other imaging modalities was not there. Um, do we required only in few cases of 4D CT, like one recent case we had a requirement of 4D CT. Otherwise, I think the requirement is pretty less. But as you rightly said, the availability of maybe is an issue even outside Lucknow. It will be an issue. The ultrasound is the best possible modality, and I think the for the peripheral surgeons, it is better to refer to the central institutes for further management. Otherwise, it becomes really difficult to accurately localize and treat those patients.
Yeah, I fully agree with your views, but Dr. Vivek, do you have any other views on preoperative localization before primary surgery?
Sir, general views per what my previous analyst has said, but in my personal practice, for me, ultrasound is a stronger modality compared to even nuclear scan. It works very well for me because I have a single dedicated sonologist for me, and that's why probably our overall results are to a tune of 85-90% for picking up parathyroid adenomas both in single as well as multi-gland disease. Multi-gland disease, of course, we may not be able to pick up all enlarged glands, but at least we can rule out that, or we can just establish that this is having at least more than one gland enlargement. So, probably a dedicated sonologist, not in rural setting, of course, I'll not say that it is possible, but in high volume centers, yes, this sensitivity can change, this specificity can change.
Okay, so I think by and large there's a consensus on ultrasound and maybe being the first line set of imaging. Dr. Navneet, do you think there's a role for 4D CT, maybe in a patient where either maybe or ultrasound or both have not localized a parathyroid lesion? Would you like to do that, or would you reserve that for patients who have a failed parathyroidectomy initially?
If the reports of these two main modalities is discordant, or either of these, sometimes they don't pick it up. It's very rare scenarios that neither the ultrasound or the maybe scan is picking up the culprit gland. Then there comes the role of other modalities like the 4D CT. And 4D CT, the good thing is that if you discuss with your radiologist, it can be done at most centers after giving a IV contrast. But the radiologist should be trained in reporting and seeing such adenomas. So yes, it is very important for cases where we are missing the glands on the routine imaging.
Okay, so we have discussed the first line imaging for localizing parathyroids. Besides that, we should be undertaking imaging for detecting any end organ damage, renal imaging and bone densitometry. Is DEXA, I mean BMD by DEXA sufficient, Dr. Shivendra, or you would like to recommend anything beyond a DEXA?
Sir, as part we do DEXA, and I think this is one of the essential tests because not only it helps in making a correct diagnosis because we expect more cortical bone loss in primary hyperparathyroidism, but also we can follow our patients after primary hyperparathyroidism surgery also, whether how much they have responded, and we can treat them also beforehand before even going for surgery. So I think DEXA scan is good. Renal imaging we often do in patients who have history of calculi. Otherwise, routine ultrasound to look for nephrolithiasis we are not doing in our patients routinely.
Okay, so
So
this
there's a
I would
patient,
like
question in
to
the chat
yes,
box.
I would like to add one point, sir. I think ultrasound to look for nephrocalcinosis becomes important because in certain scenarios, there may be nephrocalcinosis which can point to the diagnosis, and it's important to prevent further renal damage. It helps in counseling as well.
Yeah, I agree with that. I mean, a baseline evaluation for not just renal functions but also structural changes is good. So this patient had, I mean, this patient had a classical biochemical picture of high calcium, low phosphorus, and high PTH, normal creatinine. Supposing this patient had a normal calcium and raised PTH level, would this be totally exclude? I mean, would this picture totally exclude a possibility of hyperparathyroidism, or can it still be a patient with hyperparathyroidism? Dr. Sapna?
Sir, first of all, in this case, I would like to rule out the secondary causes. PTH is high, so definitely hyperpara is definitely there. Now we'll have to rule out the secondary causes like vitamin D deficiency, or so I would like to look into the levels of vitamin D and creatinine to look for any kidney disease.
Great point. So every patient with high PTH doesn't necessarily have primary hyperparathyroidism. In fact, if we talk of non-surgical practices or experience in physicians' practices, a larger group of patients would have high PTH due to causes other than primary hyperparathyroidism. So what is important, of course, we'll come to those things a little later, but what is important is that equally, normal calcium does not essentially excludes primary hyperparathyroidism. What is important to remember is the diagnosis is based on inappropriate levels of PTH for the calcium levels that we are looking in a specific patient. And so there would be patients who have close to 5% patients with normal calcemic hyperparathyroidism. And then there would be patients with high normal PTH with high calcium or normo-hormonal as they are called. So let's not forget that only about 85% patients would have a classical picture. So oops, I think I'm mixed up. So it's important to, as Dr. Sapna said, to look for causes which may cause a change in PTH levels, even though the patient does not have primary hyperparathyroidism. And this will include, most importantly, vitamin D deficiency or insufficiency, chronic kidney disease. So creatinine must be checked, hypercalciuria secondary to renal leak, malabsorption syndrome, and certain drugs. So this patient underwent a ultrasonography, and we found left inferior parathyroid adenoma. And also she underwent a sesame D scan, which showed uptake at the lower pole of the left thyroid lobe. So this patient had concordant imaging, but anyone, have I missed a point here before undertaking this imaging? Did I miss one critical point, or I omitted it purposefully? What I'm hinting at is that imaging is not to be done or considered before a decision for surgery has been made. Imaging or localization studies are indicated only for aiding surgical exploration or limiting surgical exploration. These do not contribute to diagnosis. So, are there patients with primary hyperparathyroidism in our own practices who do not have any indication for surgery? Again, because Dr. Shivan is the only endocrinologist here, I'll have to keep going back to him more often than I can go to the surgeons. Dr. Shivan?
So, very few we find, but yes, some patients who have a borderline less than 1 milligram per deciliter from the upper limit of normal. And if I'm not wrong, if they are more than 50 and no other end organ damage, then the need of surgery is not there. So we can keep them on follow-up, close follow-up. And the other point to note is if very young patients with very mild hypercalcemia, One entity is familial hypocalciuric and hypercalcemia. That also we should keep in mind, and such patients actually should not undergo surgery. So unnecessary. Then we have to go for familial screening also, look for the calcium in the family members. So but these are very rare, sir.
So only very rarely we have patients who do not have an indication. Now, I am reminded of starting of this century when there were number of consensus meetings and statements provided regarding which patients can be offered non-operative treatment, just observation. But that has been revised numerous times, and today almost all patients with primary hyperparathyroidism have one or the other indication. Now, supposing this patient did not have a concordant imaging, or the patient did not have a localization or any positive localization, even after doing, say, 4DCT2, what would be our approach? Dr. Pooja, a patient where preoperative localization has failed, what is the next logical step?
So we can go for 4D-CT or F-choline PET. So we need to do more imaging functional if possible.
Okay.
Otherwise, if biochemically it is hyperparathyroidism, primary hyperparathyroidism because of adenoma, then we can go for bilateral neck exploration if no facilities are available for these advanced imagings.
Okay, so your view is that if in case all facilities are available, we must do everything possible to localize. Is there any other view on this? Would somebody like to discuss restricted imaging or limited imaging and not using anything beyond 4D-CT or ultrasound, maybe perhaps 4D-CT? As the guidelines, majority of guidelines say, I think for primary surgery, patients undergoing primary surgery, is there any other view on this from anyone?
Sir, I would like to add that in extension to what Pooja ma'am has just said, my further evaluation depends upon few factors. First thing is, if we are sure about the biochemical diagnosis, then I would look at the level of hypercalcemia. And in my mind, I would think whether it is a single gland disease or a multi-gland disease. So if I'm suspecting it is a single gland disease, then I will, apart from doing the neck, as well as I would like to include the chest as well. Sometimes there could be an ectopic adenoma in case if it is not localized or if we're not finding it in the neck. If it is pointing towards multi-gland disease, then probably I will go for a bilateral neck exploration if I'm sure about the biochemical diagnosis. That's how I would approach it.
Okay, so I think maybe I can very well say my views are based on perhaps an old school, and the old school is primary hyperparathyroidism is cured by surgeons and not by imaging. Surgeons can take help of imaging in a reasonable way to limit the surgical exploration, but even the best of imaging modalities have at best 85% sensitivity. So you would still have at least 15% patients with primary hyperparathyroidism where you would not have a pre-op imaging, and these patients majority of them will be cured by an expert parathyroid surgeon. So I think the guidelines they document this fact very clearly that beyond the first line imaging, pick up the patient for bilateral neck exploration, identify the diseased parathyroid gland or parathyroid glands intraoperatively, and cure them. And reserve any advanced imaging, any further imaging for patients where you are not able to cure them from the initial surgical procedure. So in both the scenarios, surgery is indicated, and the goal of surgery is to cure primary hyperparathyroidism and not necessarily cure it with minimal invasive surgery alone. So there are some definitions written here on top on the screen. Is that acceptable to everyone? The definition of cure of primary hyperparathyroidism is re-establishing normal calcium homeostasis lasting for a minimum of 6 months. Is that acceptable?
12 months.
And the second statement that cure rates of parathyroidectomy in hands of surgeons with some expertise and experience in parathyroid surgery should approach 95% plus. Irrespective whether you undertake pre-op imaging or not, this will be achievable. Of course, there would be certain patients where imaging pre-op localization will be helpful, either in limiting exploration to focused parathyroidectomy or undertaking minimally invasive or even remote access parathyroidectomy. And in certain proportion of patients, it will help you cure the patient otherwise. Like the scenario that Dr. Ramya said, patient may have an ectopic parathyroid gland, but majority of ectopic parathyroid glands should be picked up by a well-performed BP scan or a 4D CT if the patient has a sizable ectopic adenoma. If the patient has multi-gland disease, neither pre-op imaging nor the standard neck exploration will pick it up, and those few or rare cases will have to be evaluated after a failed parathyroidectomy. Is there a role for anything other than surgery like ethanol ablation, microwave ablation, radiofrequency? Any takers for that? Raise your hands. Any panelists? All are welcome to stick their necks out. Oh, there's one hand going up, Dr. Vivek.
So I would restrict the use of these procedures for very specific conditions, like very sick patient, maybe a patient in ICU setting who cannot be taken up for surgery, like after maybe severe pancreatitis, or very elderly having a lot of morbidities, comorbidities. So we can do this as a bedside procedure for those kind of patients where we would not like to offer surgery, being high risk overall.
Excellent point. Yeah, I fully agree. This is exactly what the limited role these can play. In fact, coincidentally, just this last week, we had a patient referral from ICU, a patient with hypercalcemic crisis, but the patient was already with a very low GCS on ventilator. And this thought did cross our minds that we may do a microwave ablation on this patient if that sound shows an adenoma. But unfortunately, the patient didn't make it. Anyhow, so yes,
Can I?
yes,
Sorry,
please.
sorry to interrupt, sir. So I think medical options are also there. Instead of trying to do something in the neck like an ethanol ablation to poke the adenoma, I think it would be better to do medical control of calcium in these patients if they are sick. That's what I would think.
Okay, yes, you can try the medical therapy, cinacalcet and bisphosphonates, whatnot. But again, limited to patients who are not surgical candidates of very high surgical risk. Okay, we move ahead. So this patient had a focused parathyroidectomy. Of course, there's a whole spectrum of parathyroid surgical techniques available. And because I'm approaching the end time of my or the allotted time. So this patient had a concordant imaging. Which approach would you select for a patient who had a concordant imaging, non-concordant, one with a single gland disease or a multi-gland disease? So this is an important decision that a surgeon has to take for appropriate patients. So in a patient where imaging is contraindicated or it doesn't help, which means there's no concordant or even single imaging which is positive, then of course you'll have to undertake bilateral neck exploration. However, if the patient has good quality concordant imaging resulting in single gland identification, a minimally invasive parathyroidectomy with or without IOPTH is what can be done. But there would be number of patients where one of the two modalities would show a lesion, the other would not. Or you do not have confidence in what you see on imaging. In all of these cases, you can undertake a next step imaging if you want to, or else you undertake or you subject the patient to bilateral neck exploration. A third possibility is that you do unilateral exploration or minimal invasive parathyroidectomy with intraoperative pKa estimation. And in case the results are not curative, then you undertake or convert to bilateral link exploration. So I did talk about, or I did mention, intraoperative pH monitoring. So which of the intraoperative adjuncts would you like to use during primary surgery? Let me start with Dr. Vivek. Today, which adjuncts would you like to use?
So if we are planning for a minimally invasive focused parathyroidectomy, then I would be happy to have intraoperative PTH assays with the frozen section. And I think these two are more important for me. Of course, as you have listed, others can be utilized, but these would be very essential and would, I would definitely like to have that.
Okay, yeah, for primary surgery, these are the only things, but it might be worth reminding everyone that use of intraoperative PTH does not guarantee success or cure. In fact, it is more of a reassurance to the surgeon during primary parathyroidectomy that we have got the culprit gland. Its routine usage has not been shown to increase the cure rates in patients undergoing primary surgery. Of course, there would be specific conditions or scenarios where it will be of great help or rather critical help to cure the patient. So if you do not practice or you do not have access to intraoperative pKa estimation, that's certainly not a contraindication to practicing parathyroid surgery, nor is it any way a lesser standard of care being delivered. But in scenarios like reoperative stitching or patients with the possibility of ectopic glands or difficult locations, then certainly this is highly desirable or even essential. PTH monitoring can be done. I'm sure all of us endocrine surgeons are aware of these various criteria, which can be used for interpreting intraoperative PTH dynamics. But for the benefit of the postgraduates, the commonest criteria used is the Miami criteria. And then next one is a modified Miami, where instead of just more than 50% decay from the highest preoperative or pre-excision levels, what we try to do to document is drop of PTH levels at 10 minutes post-excision to within normal limits too. So if that happens, it's a very highly sensitive and specific test, but then the issue is that it doesn't really help in majority of patients undergoing primary surgery. And I think this is one sentence I like the PGs to remember: an adequate IPTA drop does not define cure, but is certainly helpful in predicting cure. There are numerous limitations of intraoperative PTH estimations, and even with routine practice of IPTH, you can still be looking at 2 to 3% failure rate with great expertise, and it does add substantial cost to surgery. It has not been shown to be cost effective in preventing failures. Now, this patient underwent a focused parathyroidectomy, had a curative drop in IPTH. Now what? This patient, the specimen was sent for frozen section histology. Dr. Chanchal, how would this frozen section histology be of help to us during surgery and eventually?
One thing we need to understand is that frozen section in case of these scenarios is not for diagnosis. It's basically for reconfirmation that the tissue that has been resected is actually a parathyroid. For a proper diagnosis, whether an adenoma or hyperplasia, it is always possible to give it on a definitive histology when the proper crossing and proper fixation of the specimen has taken place. Because frozen section has its own pitfall. Since there is a lot of fat as a result of freezing, the way we see the cell is quite different from what we actually see when it is properly fixed. So it is not for the diagnosis, but yes, for the reconfirmation that the gland is actually a parathyroid.
Can you at least tell us on frozen section histology if this is a normal parathyroid gland or a suppressed parathyroid gland versus a pathological parathyroid gland?
In frozen section, it is not always possible to differentiate even between normal and pathological, but yes, a normal parathyroid gland, depending upon the age, have a more fat content as compared to case of parathyroid hyperplasia and adenoma. So it might be a little possible to differentiate between a normal from a pathological, but in the pathological group, it is not possible to differentiate between an adenoma and hyperplasia on frozen section.
Okay, thank you. So surgeons, don't expect your pathologist to tell you whether you're dealing with an adenoma or a carcinoma or hyperplasia based on frozen section. But you can certainly push them into committing whether they are dealing with or we're looking at a normal gland or a hypercellular gland. And that hypercellularity can be as part of an adenoma or hyperplasia or even a carcinoma. But that distinction will come only on peripheral section histology and possibly aided by immunohistochemistry. So this patient, as we discussed, this is the specimen picture here. The frozen section histology identified parathyroid tissue, and the patient had curative PTH fall, and the final histology was parathyroid adenoma. I think I have Dr. Sabha. Do I continue or do I need to stop here? If he has not interjected, I think I take it that we have to continue until 8 p.m. So quickly, another patient. This patient had, other than primary hyperparathyroidism, also intermittent galactorrhea and irregular menstrual cycles with headache. So, and then was found to be having hyperprolactinemia, and MRI showed a supracellular mass, was treated on with tablet cabergoline, but then was lost to follow for almost a decade. Does that happen often, Dr. Shivanj? Patient with such a kind of difficult and serious diagnosis getting just uh, defaulting?
With prolactinoma, yes, sometimes because it is a one pituitary tumor which is treated by drug. So sometimes they come for few follow-ups and then they get lost. And I think the point missed is initially there should be a calcium levels checked at the initial time of visit or patient should be counseled. So, but
Absolutely.
Menon
So,
syndromes, yeah.
yeah, so we cannot be ignoring the commonest manifestation of MEN1, which is primary hyperparathyroidism. So this patient indeed had biochemical picture of that primary hyperparathyroidism. What genetic workup would you like to do in such a patient? Who would like to start? Dr. Ramya?
Sir, evaluation for menin gene mutation, because she has hyperprolactinemia and hypercalcemia. So menin gene evaluation would be the next test.
Yeah, so this is a phenotype fitting into MEN1. So of course, MEN1 gene mutations too should be looked at. Dr. Navneet, how often do you find the need for genetic testing in patients presenting with primary hyperparathyroidism?
So patients who are young in age, young onset primary hyperparathyroidism, or where there is a family history, or where we suspect multi-gland disease in a young age onset. So such patients, we should suspect the familial causes, and of these familial causes, the most common would be the MEN1 syndrome, and followed by MEN2 or hyperparathyroidism jaw tumor syndrome. So based on the clinical history, we have to go for targeted genetic testing, not a routine testing of all the possible genes.
Yeah. So how often do you find the need to do these? You're very right. These are the set of patients.
Sir, it is very uncommon. I would say probably about 5% patients in my setting would be requiring the genetic testing.
Anybody with a different opinion? needing, larger proportion of their patients require of genetic testing? Perhaps not. So,
I would
yeah.
like to add something, sir. Considering
Yeah.
considering our Indian setup and considering the cost of the genetic test, if you take this patient who's a young patient who has a prolactinoma and who has a hyperparathyroidism, it is he or she is more likely to have MEN1 syndrome even if we don't do a genetic testing, and we can manage the patient and follow up accordingly. Because I think majority of my patient do not have the for the genetic testing. So and uh, and I've seen MEN1 patients in two patients who were 45 plus, who were treated for a pituitary tumor and had proper acromegaly symptoms and had multiglandular disease when they came to me for the hyperpara.
Okay, agreed. So we have to make compromises, though you would like to do genetic testing, but you're compelled not to because of the logistic reasons. But be cognizant that phenotype is not always consistent with genetic diagnosis.
Sir,
Not be meant for I2? Can this not be meant for instead of just an N1?
Sir, one more important point is genetic testing also gives opportunity for familial screening and further genetic counseling. So if though it seems a clear-cut case, and if we can document the particular genetic mutation and we can screen others, it also becomes easier for other family members to follow or not to follow, because MEN1 is one diagnosis where lifelong screening for other tumors are required. So definitely I would go
Absolutely.
if possible.
Yes, definitely. One cannot overemphasize the need for genetic counseling and testing, but of course, the other part is equally correct, applicable that we though we want to, we can't test every patient. So the surgical strategy in such patients, what is the practical strategy? Do we need to always be radical, doing bilateral neck exploration, doing subtotal parathyroidectomy or a total parathyroidectomy, or is there a role for being conservative or a room for being conservative? And Dr. Pooja, in patients who have MEN1, what is the current strategy, surgical strategy? Is the old time long belief strategy of bilateral exploration, subtotal parathyroidectomy still holds true?
So now it depends, like we are becoming more conservative. So if we have localized a single adenoma, even in MEN1, we may go away with excision of that single adenoma. So, but if it's multi-glandular disease, then definitely bilateral exploration has to be done. But I think not in every MEN1 patient.
Yeah. So yes, agreed. So that dogma of and when one patients, or rather majority of familial patients having multi-gland disease requiring subtotal parathyroidectomy is being challenged now. So even for MEN2A for a long time, it has been agreed that we can be selective. We can just remove the enlarged or adenoma rather than all the parathyroids. But even for the MEN1, we now believe that we can be selective to the extent that people have now started advocating staged parathyroidectomy. One may remove just two parathyroid glands. And I think the logic is very solid. The logic is not to allow, not to put a patient at risk of permanent hypoparathyroidism. So, and if in case the patient has persistent or recurrent disease, it can again be taken care relatively easily. So localization studies in this setting, patient with a familial disease, unfortunately, the localization studies do not perform as well as they do in apparently sporadic primary hyperparathyroidism patients. So do not rely too much on them. If in case you have a solid localization and would like, and then the possibility of asymmetric hyperplasia is there, or multiple adenoma is there, one can be selective. But by and large, the notion continues to be that you do bilateral neck exploration and not focused parathyroidectomy. So this patient had a well-defined lesion below the right lobe of thyroid and maybe also showed a right paratracheal region lesion. She had osteoporosis and prolactinoma. So what next? What surgical procedure should we do? And as we have
Sir,
discussed
I think the
already,
audio is disconnected.
hello, am I audible?
Yeah, it's portable.
Yes, sir.
Okay, so this is what we have already discussed that in MEN1, the conventional procedure has been subtotal parathyroidectomy. However, we can be a little more selective now. And while we are doing it, we also do bilateral cervical thymectomy. And that is to take care of any ectopic parathyroid glands and also to reduce the risk of thymic carcinoids in future in MEN1. And in MEN2A, we resect only the visibly enlarged glands, possibly only the adenoma excision. But if in case you're dealing with a multi-gland disease, of course, an appropriate multi-gland surgery is required. In patients who have hyperparathyroidism, jaw tumor syndrome, or familial isolated hyperparathyroidism, optimal surgical approach continues to be elusive. So surgeons have to select the right one based on the individual patient's requirements and not go in with a preset or predefined notion of doing one or the other procedure. But both these conditions require a lifelong follow-up to detect any persistent or recurrent hyperparathyroidism. So this patient, we undertook bilateral neck exploration and 3-gland excision rather than 3.5, because the idea is today to leave behind well-functioning parathyroid tissue equivalent to one normal parathyroid gland in the neck. Uh, I mean, the comparison between subtotal and total has now been laid to rest. Total parathyroidectomy seem to be an overkill, and it does result in higher rates of permanent hypoparathyroidism, and not much not much compromise on cure of primary hyperparathyroidism. So such a 3-gland excision is also equally called subtotal parathyroidectomy, and this can result in lower probability of permanent hypoparathyroidism. So, Dr. Chanchal, when you receive such multi-gland specimen, what is your view? I mean, do these patients have universally hyperplasia, or do you subscribe to the recent view that the WHO classification of parathyroid tumors state that these are multiple adenomas?
So Chanchal has just now left.
Okay, all right. So I think we have overshot the time and then the panelists are leaving. So that's a hint for me to wind up. But in the remaining time, yes, so there is a new thought about not all multi-gland disease is hyperplasia. In fact, vast majority are multiple adenomas, and well, we'll learn more about it in coming years. Surgical complications in hands of experienced surgeons, the overall morbidity should be less than 4% and no mortality is acceptable. And I think failure of surgery is the commonest or the most dreaded complication. We should minimize it at all costs. Of course, hypoparathyroidism is the other common one, and recurrent nerve palsy and other related complications are fortunately rare. Postoperatively, these patients require supplementation with calcium and active vitamin D or cholecalciferol and appropriate follow-up, assessment of cure at least at 6 months and 1 year, and if in case there's a recurrence, appropriate evaluation. So I think we have covered some bit of management of primary hyperparathyroidism. I would like to thank all the panelists. In the end, if any of you have any point to make regarding management of primary hyperparathyroidism, please feel free to raise your hands and come up with that, and then we can wind up this panel discussion. Any parting thoughts from all of you, Dr. Shivendra?
No, sir. Mostly things are discussed.
Dr. Pooja? Okay, Dr. Navneet.
No, sir.
Dr. Ramya.
No, sir, I think everything is discussed.
Dr. Vivek.
So one or two questions I would like to ask is, one is that suppose we have a patient of hyperprolactinoma, do we need to look for calcium as a part of routine evaluation? Second, if in a familial setting like MEN1 and all, what would be the guidelines for doing imaging? Or would we still like to sort of image and try and find out the more functioning glands? Since now we are, the philosophy is to do less and less. So, selective parathyroidectomy. So, suppose in MEN1, a patient comes to us with hypercalcemia, hyperprolactinemia. What imaging should we do?
Oh, okay. So let me take up the second part just for this to ensure that we do not spend too much time on it. We discussed imaging is still can be done similar to what we do for sporadic ultrasound and maybe to begin with. Essentially to look for an ectopic and supernumerary glands because that will not dictate the extent of surgery by and large. The extent of surgery or approach to surgery would continue to be bilateral neck exploration. But then during surgery, you can be selective. You need not always uh, need to do subtotal parathyroidectomy. If you find that you have located the parathyroid, they're normal looking, not enlarged, and one or two of them or few of them are enlarged, you can be selective. You do not have to necessarily do subtotal because that raises the risk of hypoparathyroidism. Now, the second part of the question that you asked, I think Dr. Shivain would be a better person to answer. Of all patients with prolactinemia, what proportion would eventually be found to be having hypercalcemia?
Uh, Sir, exact percentage I'm not remembering, but as part of the protocol, since calcium is a cheap test, it should be done in all patients of prolactinoma, though I think 5 to 10% of the patients we do find like they have high calcium. And similarly, the glucose levels also we check because they can have insulinomas. Regarding the other imaging modalities, so if the functional tumors we suspect, like acromegaly, IGF-1 has to be done from the second decade onwards because insulinoma can come earlier also. Then in the late first decade or in the early first decade, PHPT can occur. So we should start monitoring for calcium from second decade onwards. And for pituitary tumors, regular imaging is required because many times it is a non-functional pituitary adenoma. It may not secrete anything, but the frequency is individualized of how frequently you should do the pituitary imaging in these patients.
Thank you. Dr. Ramya, any final thoughts from you or can we wind up? Okay. And there are a couple of questions in the chat box. One of them is from Dr. Shashi Moli. He's asking regarding availability of CT scans in rural setting. Well, this was something very similar to what was discussed in the previous discussion regarding adrenal pathology. So, yes, CT imaging is somewhat better available compared to maybe or nuclear scans for sure. But then, even that, the best is to have the patient referred to a better center with all facilities. And also in the chat box, Dr. Chanchal Rana has left a couple of messages regarding immunohistochemistry does not have much role in differentiating adenoma from hyperplasia. However, it can be helpful in differentiating carcinoma from the rest. And then also that is by loss of parafibromin expression is strongly associated with parathyroid carcinoma. But then atypical adenoma also a substantial proportion of them have loss of parafibromin staining. So I think we have come to the end of this panel discussion. Thank you all very much, all the panelists, and thank you, Dr. Samaratnam, for involving the Indian Association of Endocrine Surgeons in this ASRI conference this year. Over to you, Dr. Sabha.
Thank you so much, sir. Lovely panel discussion. We all enjoyed that, actually, in-depth panel discussion. Now we come to the next session of this today's thing is head and neck. I request Professor Amit Kesari, Dr. Indu Shukla, Dr. Nasreen, and Dr. Rudra Pratap for to join and carry forward. And actually, the rapporteurs for this session will be Dr. Priyanka and Dr. Rijuta Afel. Dr. Priyanka is there? Okay, if she is not there, I request Dr. Amit Kesari, who is the head of head and neck surgery here, and he's my very close friend also, to take over the thing. And next 1 hour is regarding head and neck surgery. They will talk about benign lesions of the neck as well as tracheostomy, which is very important. Over to you, Dr. Amit.
So thank you, Sabba, and this is my second experience with this Association of Rural Surgery of India. One conference we had in SGPGI, and we would be next 1 hour talking about one is tracheostomy, then we have the parapharyngeal tumors by Dr. Nazreen, and then we have the complication in head and neck surgery whenever we address any tumors in and around neck, we will have complication of head and neck surgery. And then there are the pre-malignant and benign lesions in oral cavity by Dr. Rudra. So I will start my presentation with my presentation on tracheostomy. Okay. So is my screen visible?
Yes, boss. Yes, boss, visible. Very well.
Okay. Okay. Right. So coming to the tracheostomy, it is one of the important procedure that every surgeon should learn, even in any setting, be it at ASRI Care Institute or you are working in a hospital, because it's an emergency procedure to secure the airway. Coming to the indications in head and neck surgery, any upper airway obstruction due to compression by mass, upper airway obstructions like acute epiglottitis, or any lesions which got supraglottic just before the vocal cord, supraglottic edema. There can be tracheal infiltration by malignancies like some thyroid cancers. Tracheomalacia rarely require this tracheostomy after doing a thyroid surgery for a large goiter. Laryngeal edema with impending airway obstruction, sometimes it is needed in the emergency. Bilateral vocal cord palsy with impending airway obstruction. Bilateral reductor palsy can cause airway obstruction. So for the prevention of that, either we do a Casima procedure, which is essentially a cordectomy along with the part of cord is removed along with the arytenoids. And when we are planning a long-term ventilation in ICU, then we have two options. Either we can do a percutaneous tracheostomy, which is mainly done by the intervention people, either in ICU, or we do a open tracheostomy. So coming to the how does the tracheostomy help us? It reduces the upper airway dead space by up to 150 ml. So because the upper airway is bypassed and directly the lung is being ventilated, and it significantly reduces the effort of breathing, significantly reduce airway resistance and increase alveolar ventilation, most comfortable than endotracheal tubes, and better tolerated by patient and require less sedation. If in an endotracheal patient, if the patient is even kept for more than 5 days, then it is not tolerated, or patient has to be sedated even for few hours. The patient need to be in sedation. But if the patient is conscious, then tracheostomy is better tolerated to prevent any airway. And sometimes it's when we do a head and neck surgery, it is required to prevent the aspiration in when we work in tongue, buccal mucosa, or pharyngeal space. The patient can potentially eat and talk with the tube if there is a speaking valve available. So coming to the tracheostomy, there are various tracheostomy tube. The ideal tracheostomy should be rigid enough and maintain the airway and it flexible to limit the damage uh, in the trachea when inside the trachea, and also should have comfort. Then there are pediatric, neonatal, cuffed, uncuffed, and we will talk about them in detail. So this is the usual Portex cuff tube. This is a silicone tube. So when we are wanting the tracheostomy tube to be longer, maybe for a few months, then we use the silicone tube. This is the tracheostomy tube, which is metallic. So metallic comes in different sizes. Usually we multiply by normal tube. If it is 6, then we multiply by 4. So we need a 24 number tube. Then in pediatric, for very small kids, cuffed and uncuffed both are available. But if the child needs to be ventilated, then we have to use a cuff tube. And then the fenestrated tube are available when we want the patient to speak, because so that the air can pass through this. And we can also use a speaking valve along with this for patient to talk if the patient does not want to put hand on the tracheostomy. Coming to this fenestrated tube, it is available with and without cuff. Useful when a stable patient is weaning off from tracheostomy and require both period of confiltration and deflation, and need a speaking valve, as I just told. So the other varieties available are extra longs when we have very obese patient, or if the trachea is if some obstruction is in the upper part of the trachea, then to bypass that we need this. You can see there is a adjustable flanges. We can use adjust these flanges, and then we can make it longer. So it can even go up to the carina, but in very obese patient, more than 110 kgs or 120 kgs, we need especially this tube, which is available. Tube sizes is depending upon the age for children, but usually for female patient we use around 6.5 and 7, and for adult patient we use 7.5 to 8, depending upon the size. We can calculate the size according to this formula also. Coming to the surgery, how do we prevent complication during surgery? Is the localization of trachea is very important. The patient position is neck extended position, and we have to then the insertion of tube should be taken care. The tube, before you remove any retractor, the tube should be confirmed, and then the tube should be fixed so that it does not split. And the skin incision, if it is big, it need to be sutured to put the tracheostomy tube in place. So this is the tracheostomy set, which essentially consists of some retractor, tracheal dilator, and all that. This should be a sterile. Along with we can have a cut seat, or the cut seat is now available. Single-use cut seats are available. This is the tube, and this is the direction to which the tube is put, and this is how it is hold. So it is start when we insert the tube, you put it horizontally and then rotate it vertically down, so that it goes into the track without going into the false track. And coming to the surgical step, the normal painting drop-in, you can see the position of the tube. And also, if the patient is in ICU, you need to palpate the tube. You can palpate the tube once you are into the skin, subcutaneous, and layers of strap muscles. So lignocaine, adrenaline interflation 2%, lignocaine with adrenaline is infiltrated. The landmarks are marked mainly the thyroid cartilage, cricoid cartilage, and the suprasternal notch. And we make an incision between either vertical or horizontal incision between the cricoid and the suprasternal notch, which is roughly is around third tracheal ring. The incision can be either horizontal for a good scar, or it can be vertical, depending upon the choice of surgeon. We cut the skin, subcutaneous tissue, and then we dissect in the midline for the strap muscles so that they can be retracted. And if the so you can see that the strap muscles are being retracted. This is the thyroid hook, single hook, which is taken up so that cricoid can be fixed if required. or it is also used as a second source of retraction, superior retraction. And after dissection, sometime the thyroid tissue may come, which you can take with this retractor or any of the retractor. Then it is the trachea is confirmed. So at this point, we take some water into the syringe and then aspirate the trachea. So this give a confirmatory finding. Also on the trachea, there is a pretracheal fascia, which need to be incised before you do a tracheostomy. If the patient is already in the tracheostomy tube, then the tube need to be withdrawn by the anesthetist or by your assistant, such that it is still at the level of vocal cord, but it is away from the your area of incision. Then trachea incision is made, and then after making incision in trachea, either you can do a crisscross incision, or you can do a cross incision. You can remove part of the this trachea. Especially in old age, it is very calcified, so you need to take care of that calcification. Sometime, very rarely, we have to use a drill. Otherwise, usually a 11 number bed take care. And while incising the trachea, you have to take care that you do not injure the posterior wall of trachea, which is important to prevent any tracheoesophageal fistula. Then after opening the tracheostomy, it is dilated with the tracheostomy dilator, and then we put a tube, and it is fixed on both sides, and the two fungus are put in between so that the tube is not very tight. And once this is done, you confirm with you do ambu mask, and then you confirm the bilateral chest air entry that it is equal. Yeah, and if the patient is on ventilator, you can do the EtCO2. You can see the EtCO2, which is one of the most confirmatory part. And before everything is confirmed, the tube is in place, you do not remove retractor, because sometime rarely it can go into the false track, and the patient may not ventilate. So that's why the tube is already in place in the nose, and if the in the larynx, and if it is the patient is not ventilating, it is just slid under the vision to the trachea again, and then everything is readjusted the tracheal, and we can re-explore before we put the tube. This is the pediatric size estimation, neonate, and depending upon adult, what is the internal diameter, and depending upon the branch, we can use this as one of the guiding factor. But as I told, that for females we use 6.5, 7 tube, and for male we use a little larger tube. When the patient is not ventilated, if it is on a ventilator, then there is a different kind of mask. Then heat moisture exchange, so this prevent dryness of the tracheostomy tube, and it is a very good exchanger, and it is now commercially available, can be put on the tube. Then if the patient is on for total laryngectomy or any other procedure where the tracheostomy to keep long term, the tracheostomy bib is also available to cover the wound. Nebulization can be done through the tracheostomy. If there is a secretions and other thing, we can use the normal nebulization with other thing, and we can also use mucolytics for the nebulization if there is a thickened secretions. Suctioning is important, and usually every 2 hourly the suction is done. And initially it is more important. Slowly the patient gets adjusted, and it is to be trained. You can see the direction of the suction. It should not go very deep, but it should be deep enough to remove all the secretions. And suction, what are the sometimes the repeated suction may be required if there is abnormal breath sound, irregular respiratory pattern, if the secretions is very thick in quantity and lot of secretion, the patient is coughing, if there is a sound, and if the oxygenation is getting down, then you need to see. So a tracheostomy patient, especially in ICU setup, need to be watched. The suctions which are available for home, this is the what is available in the ICUs most of the time. This is for the home suction, and this is what is available in OR and in other areas of the ward. It is usually available. This is the wall mounted for central suction. So the suction apparatus, all of these works depending upon the situation. If you are sending patient home, this electric suction is very good for home use. And we teach patient that how to avoid, how to do a suction, and what is the to be taken if there is a tube blockage. Then complications can happen intraoperative, early, late, long term. the most important complication, which is the blocked tube. So when there is a blocked tube, it need to be changed. If the tracheostomy is 7 to 10 days or more than 15 days old, then a stoma is usually formed. We recommend using a tube, which I told earlier, with the inner and outer tube, either metallic or silicone, which the inner tube can be washed under water, and it can be so this prevent blockage. But if the tube is blocked, it need to be changed, because it is then it can lead to the serious complications if the tube is blocked. So it usually happen on initial 1 or 2 days, or if the secretions is very thick, or if there is a bloody thing which is in the upper airway. Then hemorrhage, airway fire, which are injury to trachea, larynx, paratracheal tissues can happen. Sometimes the bleeding can happen from the anterior jugular vein. Then we need to take care of it, either bipolar or you have to take sutures. Sometimes the thyroid, mainly the stomach of thyroid or some thyroid tissue can bleed. Then also you have to take care of the lower part. On the lower part, especially in short neck, the patient may have the pleura coming into view, so it can lead to subcutaneous emphysema, pneumothorax, pneumomediastinum, tube displacement and blockage. I have already talked about wound infection, pus culture directed, and we also do a X-ray chest. We always recommend to do X-ray chest to identify any pneumothorax which may happen incidentally. And secondary hemorrhage can happen, most probably if there is a tracheoinnominate fistula, then it is a little life-threatening condition. Otherwise, a small bleeds can be managed with conservative management, increasing the cuff of the tube and putting a crusting around the tube. There may be granuloma formation, tracheoesophageal fistula, difficult denudation. This happens after the long-term tracheostomy, and especially in children or post-traumatic cases where there is a trauma to the larynx, or some cases because that sometimes the tube is the cuff is too high to necrose the trachea. Then the complications need to be managed accordingly. What are the complications? And it's like that the complications can happen, but most common complications are tube blockage, hemorrhage, which are initially there. Tube may be dislodged, but in cases where there is already a tracheostomy in place for 2-3 weeks, a tube, if it is dislodged, it can be removed. With a blocked tube can be removed, and it can be put by at home by the. We also teach the relatives to change the tubes at home. Also, they put T-tube. Tracheal stenosis is a different segment. The patient will have difficult detonation, and then we can either manage it endoscopic, or sometimes the open approach is required. Hemorrhage we talked about, that is the secondary from skin edges, which is very in the previous first or second day. This is a tracheoinnominate fistula, which is very dangerous, and then we need to identify. There will be always some sentinel bleed, which we need to take care. Then apnea, sometimes the oxygen, the retention of carbon dioxide when we do a tracheostomy can cause temporary apnea. Uh, so we don't need to worry about. We have to ventilate the patient, and then slowly it's come back. The cardiac, we have to also see the heart rate and other thing while we do a tracheostomy. Emphysema, I have already talked about. If you do not remove the pretracheal fascia, it can cause emphysema. Tube blockage, tube tracheal necrosis is very rare. The granuloma formation is important. It is happens due to, if it is around the anterior part, we can excise the granuloma. It's not a, if it happen on the inside part, then it has to be removed bronchoscopically under vision, and then we can inject steroid to prevent reformation of granuloma. Tracheoesophageal fistula is if we take care during the tracheostomy and the cuff pressure and all that, then it does not happen. If it happen, then it need to be surgically managed. Scar is not there. Speech valve, I have already talked about. Speech is important aspect of communication. Fenestrated tube, and there is a one-way valve which help the patient. So if the patient is on tracheostomy, we can use the one-way valve where the air can come in, but when the patient speaks, the air goes out through the larynx. So this is available commercially now. And then coming to the decannulation is usually we do a stage decannulation. We decrease the size of tube by one initially, and then we do a closure of tube if the tube is closed, and if the ventilation is happening, then it's not then we can remove the tube. Sometimes we do indirect direct laryngoscopy to see the vocal cord mobility, and x-ray chest to see if there is any thing and any problem. We do a bronchoscopy to see if there is a problem in subglottis area and granulation tissue, which can happen. Decannulation, we have the patient should not have aspirations, no granulation tissue, ability to tolerate tube closure. Then management of a stoma after decannulation is easy. Even after in such big tracheostomy, we put gauze pieces and a strap, and it heals within 3 to 5 days. And we just have to see the air does not leaks. It heals in its own, so we don't have to take care. So if there is any questions on tracheostomy, I can take. Otherwise, Dr. Indu will speak on complication in neck surgery. So Indu, I think if there is any question in chat box, I will. Is there any question in chat box?
So not that I can see.
Okay.
There is no question either in the chat box nor in the YouTube also.
Right.
Thank you, boss. Then Dr. Indu can continue.
Yes.
Sure.
Dr. Indu, can you please take over? Yes.
Good evening to all present. I hope I am audible and my screen is visible.
The screen is not visible, Indu.
It's not visible, sir.
Uh,
I've shared the screen, but
Yes, ma'am. We can see the screen. Your
Okay,
slide
okay.
is
Screen is
visible.
visible now.
Yes.
Okay.
And you're
Okay.
audible also.
Okay, thank you. Good evening to all present. At the outset, I'm very thankful to the organizers for giving me this opportunity to speak on one very important topic when we talk about neck surgeries, that is the complications of neck surgery and how are they managed. Since we are discussing benign lesions of the neck today, so it's very important to discuss the complications as well. So we all know the Murphy's law, which states that if anything can go wrong, it will go wrong. So this pessimistic law is somehow a reminder that unless attempts are made to avoid complications, they are very likely to occur. And complications following head and neck surgery, they are inevitable and very important to know, because right from the preoperative period, they form an essential component of our preoperative counseling, and we should also obtain informed consent accordingly. So when we talk about complications, we can broadly classify them into three categories. There can be wound complications, which includes wound infection, dehiscence, flap necrosis, and wound scarring. There are a number of neural and vascular structures in the neck, so we can have nerve-related complications, including sensory and motor nerve injuries, which affect the functions of respective nerves. Then there can be vascular complications. There can be hematoma, thrombosis, arterial ruptures, etc. When we talk about these complications, there are certain risk factors which predispose patients to develop complications postoperatively. The broader ones I've included here, one is comorbidities. If the patient has a cardiac problem, a respiratory issue, or there is a hepatic disease, then there is an increased chance of a postoperative complication. If the patient has immunosuppressive factors like diabetes and malnutrition, then the patient is predisposed to wound infection. If there's a history of a prior treatment, like the patient has received a radiation therapy pre-op, or if he has received a chemotherapy, then there can be a delayed healing and increased complications. And also one very important factor, if the patient is a smoker, then he can have an impaired vascular perfusion and also an impaired pulmonary function, and then he can have associated complications. So the dictum is that the prevention of complications, it begins with a thorough evaluation. So when we are evaluating our patient preoperatively, we have to take a careful history. We have to inquire about any previous surgery, any previous therapy, radiotherapy, chemotherapy, and any coexisting medical conditions. We have to assess the lesion that we are taking out by surgery. We have to assess the location of the lesion, the size of the lesion, the firmness, its relation to the surrounding structures very, very carefully by clinical evaluation. And also we have to read our scans very carefully. We have to encourage our patient to quit smoking, because smoking
impairs vascular perfusion, delays healing. So we have to encourage the patient. Then there has to be very coordinated team effort between the anesthetist and the operating surgeon in the operating room, pre-operatively and post-operatively as well, to deal with these complications. So if I would like to classify these complications, I would say we can classify them into major complications, minor complication. Then based on when they are presenting to the operating surgeon, they can be early complications, intermediate complications, or late complications. Then based on what part of the body they are affecting, we can have local complications where we have operated, or systemic complications affecting other parts of the body. Then there can be certain general complications and specific complications. So on the whole, when we talk about neck surgeries, head and neck surgeries, around 20% of our patient will have major complications, and the mortality rate in the literature is said to be around 1%. So first of all, talking about immediate local complications. So whenever we are taking rounds in the post-operative period, sometimes we remove the dressing, we see such a wound where the skin has turned bluish, there is bruising all around. So that is usually because of bleeding. So it is very, very important that this bleeding is detected early and it is addressed early. So the likely potential sources can be along the suture line. There can be a bleeding of the skin flaps. There can be a vascular bleed, either arterial or venous. And sometimes the drain that we have inserted in the neck, it is not functional. As a result of it, whatever small oozers are there, they basically tend to keep collecting underneath the skin and present to us in this dreadful way. So how do we treat this? First of all, we have to resuscitate our patient, put a wide bore cannula, try to replace whatever volume the patient has lost. Either it can be in the form of IV fluids, in the form of colloids, or in the form of blood transfusion if there has been a massive blood loss. Then we have to stabilize vitals of the patient, try to identify the cause of bleeding. If there is a dark venous blood, then we can apply pressure bandage. Sometimes it is controlled in that manner. But if there is a fresh oozer, then it is likely to be an arterial bleed. Then most likely we have to take the patient up in the OR for a re-exploration and control of the bleed. Sometimes there is massive blood loss because of this post-operative hemorrhage, and the patient has an insufficient volume replacement. So the patient can also land up in a situation of shock. In that case, we should always be prepared. We should always be before this, we have to be prepared with the wide bore cannula. We have to immediately replace whatever blood volume has been lost with a packed cell transfusion, and we have to stabilize the patient first and then handle the bleeder accordingly. Second massive or very dreadful complication that we can encounter in the post-operative period is airway obstruction. Now, since we are dealing with the neck dissection, we are dealing with neck surgeries which are having a very close association with the trachea. So there can be edema due to extensive resection of tissue. There can be sometimes blood, mucus, or secretions that have trickled down and they have plugged the ET tube. So when we are anticipating that the patient can develop airway obstruction in the post-operative period, we should ideally plan a pre-operative elective tracheostomy. And what dictum we tell our residents in our head and neck oncology practice is that if a tracheostomy comes in your mind, if you think the patient needs a tracheostomy, then that is the time to do it. Go ahead with tracheostomy, and the rest of the things can be dealt with later. Next complication in the immediate postoperative period can be an increased intracranial pressure. Now, whenever we are doing radical neck dissection, we ligate internal jugular vein on one side. Like in this photo, we can see that this patient has developed a massive edema on the face. What happened was the patient was having there was a left radical neck dissection with ligation of IGV done on one side, while the anesthetist did a central venous insertion in the IGV on the right side. So ultimately, the venous outflow of both the IGVs became compromised, and the patient ultimately presented in the immediate postoperative period with this picture. Now, how do we handle this? First of all, we will see that our patient will become restless, he will have headaches, there can be slowing of pulse, there can be increased blood pressure, swelling over the face, there can be pink and warm extremities, which suggest ligation of major neck vein. Then how this can be prevented? We can avoid dressings around the neck, restrict neck hyperextension. Patient can be kept in sitting position, and once this situation, we have landed up in this situation, then patient is kept in sitting position. We can give IV mannitol, we can give IV steroid, restrict the fluid intake of the patient, and then the patient will settle probably within the next 24 to 48 hours. Next, other IGV complications that we can think of is thrombosis. It is said to be occurring in upwards of 15% cases because we are handling tributaries of the internal jugular vein and the internal jugular vein as well. So the dictum is whenever we are handling a major tributary of the internal jugular vein, it should be ligated away from the IJV so that there is a very less chance of thrombus formation and luminal narrowing of the IJV. Other than IJV, what other vascular complication in the immediate postoperative period we can think of is carotid artery, which is basically the most feared sequelae. There is around a 3% chance of an acute rupture rate which can occur during radical neck dissection, and there is around a 50% mortality rate with an intermediate type of complication that is carotid blowout, which I'll be discussing later. Now, I told initially as well, there is a lot of neural and vascular anatomy and anastomosis when we open the neck. So a lot of nerves are at risk of injury. So the nerves that may be involved can be facial nerve or its mandibular or cervical division, hypoglossal and lingual nerves, vagus nerve, sympathetic trunk, and phrenic nerve. So these are certain pictures. In the first picture, we can see there is marginal mandibular nerve palsy. There is deviation of angle of mouth. In the second picture, we can see the drooping of shoulders, spinal accessory nerve palsy. Third, we can see deviation of tongue. There is hypoglossal nerve palsy. Fourth, we can see meiosis, ptosis, that is cervical sympathetic palsy. So all these nerves, they come in the field when we do neck dissection. So the dictum is that we should know the anatomy initially. Whenever we are dissecting, try to go ahead with a blunt dissection while working around nerves, and do not use monopolar cautery around nerves. When we are using bipolar cautery, try to use maximum irrigation so that there is a very less thermal injury to the nerves which are surrounding. Then we can also have certain general complications in the immediate post-op period. Patient can have pneumothorax because we are dealing with the neck which is closely related to the cervical pleura. So patient can become restless, cyanosed or dyspneic. Clinical features would be there on percussion, we will have hyperresonance. On chest x-ray, we will say hyperinflation. There can be diminished breath sounds. There can be tracheal deviation. And ultimately, we'll have to handle the pneumothorax accordingly. Then in the intermediate postoperative period, that is around 48 hours later, we can also see certain complications in the local site that includes chylus fistula, seroma, skull base syndrome, wound infection, failure of skin healing, carotid artery rupture, flap failure, and fistula formation. So discussing in brief these complications, first of all, chylus fistula. It usually occurs when we are operating on the left side of neck, particularly when we are operating in the lower part. The incidence is around 1 to 2.5%. And ideal case scenario, the best case scenario would be we should identify chyle duct injury during surgery. We should ask the anesthetist to give positive pressure ventilation, Valsalva maneuver, and once we see some milky or whitish fluid in the lower part of the neck, we should try to ligate or we should try to clip the chyle duct. And if we are somehow not able to identify intraoperatively in the postoperative period, we will identify that there is a dramatic increase in the suction drain after the patient is fed. So sometimes this can also occur when we are operating on the right side from the jugular lymphatic duct on the right side. So patient will present to us either in the form of chyloma, like we can see the above picture, wherein there is a huge swelling, and when we aspirate, we get a whitish milky fluid. There can be a chyle fistula, persistent serous or milky secretion. There can be chylous thorax, which is the most dreaded complication. Also, because the patient is losing chyle continuously, he can have dyselectrolytemia like hyponatremia, hypokalemia. So electrolytes need to be measured regularly. And how do we manage this situation? If the leak is less than 400 ml per day, then we go for a conservative management. We keep the patient nil per orally. We keep patient on a low-fat enteral diet, and we do a pressure bandage in the supraclavicular fossa area. But if it is a major leak, then we that is more than 600 ml per day, we usually need to open the lower part of neck, find the injured duct, and oversew the injured duct with silk. Then comes another intermediate local complication, that is seroma. That is, there is a pocket of clear serous fluid that is formed usually in the supraclavicular fossa area. Why the supraclavicular fossa area? Because this is the most dependent part, and this is usually seen 48 hours after the removal of neck drain, which was till now keeping the negative pressure on and was taking out all of the serous fluid. So fossa, this supraclavicular fossa usually has a dip when patient hunches his shoulder. Once we land up with a seroma, what we can do is we can do repeated wide bore needle aspirations. We can put pressure dressing, and usually it subsides by fibrosis in the coming 3 to 5 days. Another syndrome that the patient can develop in the intermediate period is skull-base syndrome. There can be temporary paresis and dysfunction of lower cranial nerves, temporary facial paresis, changes in voice or difficulty in swallowing. Usually, patient needs to be counseled very well if he develops this syndrome and given conservative treatment, and he improves over time. The next and the most common type of complication that all of us surgeons usually encounter is infection. Now, when we talk about postoperative infection, there are four most important factors that we need to remember: that it can either result from contamination of surgical field. A contamination of surgical field is more common in our surgeries because we usually have an in continuity neck dissection and work in the oral cavity because of primary excision. Then postoperative hematoma sometimes becomes infected, and sometimes there is flap necrosis and that becomes infected. So wound complications, how they can be prevented are: firstly, there should be an adequate surgical site preparation. We should remove transient bacteria and decrease the resident flora. Remove beard hair immediately prior to surgery. Incision should be meticulously designed. Flap elevation in the neck should always be in subplatysmal plane to maximize blood supply. And unless the disease is dictating otherwise, try to stay in the subplatysmal plane only. So failure of skin healing, minor wound breakdown is not uncommon. So it can be prevented by a meticulous skin incision, prophylactic good antibiotic, post-operative surgical drain placement. General factors like patient's nutrition, uncontrolled diabetes, anemia, etc. have to be looked after and need to be addressed to prevent this complication. Then in the intermediate post-operative period, sometimes we see that there are multiple small bleeding episodes in the patient and they are aggravated when the patient is coughing. Then we should always think of in mind that we are dealing with an internal jugular vein rupture. How do we manage this? Because it is a venous lead, initially keep a good amount of pressure, and if it does not settle with pressure, then take the patient to the OR and address the bleeder. Then another very dreaded complication that we can encounter is a carotid artery rupture. It is basically because of a culmination of several complications. Like we have a patient who was previously irradiated, the entire skin is fibrosed, wound breaks down due to improper incision. Like in the diagram also we can see that at the T-point junction the wound has broken down, exposing the underlying carotid artery. So once the carotid artery gets exposed, then there is a gangrene of the wall and thrombosis of vasa vasorum, and ultimately there can be a rupture of the artery. So common sites of rupture can be carotid bulb at the bifurcation, common carotid artery just inferior to bulb, internal carotid artery beyond the bifurcation as well. So how do we prevent this? Whenever we are doing a neck dissection in an irradiated patient, we should always try to protect our common carotid artery and the internal external carotid artery by placing some amount of tissue between the skin which has already been irradiated and this major vessel that we are trying to save arteries of the vasa vasorum so that the vascularity is maintained, avoid stripping of adventitia of the carotid sheath. And once, unfortunately, if this complication has occurred, we have to be very careful that there is always a sentinel bleed in the pre-carotid blowout phase. Carotid blowout never occurs unheralded. So initially we will encounter 100 to 200 ml of brisk, brief, self-controlling bleed. And after that, the patient usually has a frank blowout. So we have to keep cuffed tracheostomy tube ready, keep 4 units blood cross-matched, whatever dead tissue we can see around the carotid artery that needs to be debrided so that it does not eat away the wall of the vessel, and always keep the patient vitally stable, build the hemodynamics of the patient, and try to isolate the carotid artery and try to take a transfixation stitch before the frank blowout if it is feasible. Then important complication would be flap failure. Sometimes we can have a frank failure of the skin platysmal flap also because we have not gone into the right plane. So we have to always keep checking the color, temperature, and the presence absence of capillary refill time in the texture of the skin flap. Predisposing factors for necrosis of skin flap can be if we have taken a very bad, not meticulously designed incision, if patient had a preoperative radiotherapy, if we are using too much of monopolar cautery near the skin, if there is a constant traction by sutures anchoring skin to drapes, and if there is a drying of tissue in between. So that is why we always ask our residents to keep the skin flaps wet, keep irrigating them with saline during the time of surgery because the surgery usually lasts for hours altogether. Another complication can be fistula formation. Predisposing factors would be a patient who has received previous radiotherapy. There is an inadequate control of nutritional status, diabetes, anemia. There is a poor operative technique like a poor suturing, untreated seroma, hematoma or abscess, post-op anemia, hypoalbuminemia. So once the suture line gives away, occurs when a suture line gives away and when tissue becomes necrotic. So management would be, if it is along the suture line, it usually tends to close spontaneously. So try to avoid epithelium formation along the edges of the fistula tract so that that can be sutured later. Established fistula closure must be obtained both internally and externally, and the gap between internal and external components should be we should try to fill it in with vascularized tissue. Then these were all local intermediate complications. When we talk about intermediate general complications, we can have basal collapse, unilateral basal collapse, or bilateral in first 48 hours. Treatment is vigorous, physiotherapy and appropriate antibiotics. Bronchopneumonia, it relates to coexisting smoking-related lung diseases, associated tracheostomy and lengthy surgeries. Treatment would be again physiotherapy and proper antibiotics. Then when we talk about late complications of neck surgery, we can have a recurrence of the disease that we had tried to address. They can be parotid gland tail hypertrophy, which is a common complication, which can present with the swelling at the amputated tail of parotid gland after a few weeks of radical neck dissection. There can be lymphedema when both the internal jugular veins are tied due to interruption of lymphatic drainage from head. We can see in the picture, the steps to minimize would be we should not do any neck dressing. We should keep the patient sitting upright, give steroids, give mannitol, and the patient usually improves in a week or so. Then after the wound has healed, there can be hypertrophic scars. So this is one of the most under addressed complication of the head and neck surgeries. So in the end, I would like to say the key to successful outcome of any surgery is a high level of expertise. Surgery of neck requires familiarity with complex regional anatomy. There has to be a proper preoperative planning. There has to be a thorough evaluation and preparation to minimize risks of complications. There has to be an early recognition, identify your complications promptly, and try to manage them as early as possible. But always, as a surgeon, we should remember that complications can occur despite the best of the efforts. And just I would like to end my presentation with one quote which I always follow, that what the eye doesn't see, the mind doesn't know, and it doesn't exist. So the moral of this quote is that we should always know the anatomy very well. Only then we will be able to identify what complication we are facing and what level the injury has been done, or whatever complication, how it can be managed. So this is very important when we are dealing with neck surgeries. Thank you very much. If there are any questions, please. Hello.
Thank you so much, ma'am. I don't think there are any questions in the chat box also.
Okay.
Sabaratnam sir can tell us more if there are any questions.
Sure. I think sir is muted or something.
Probably we can move on to the.
Ha, Dr. Indu, very nice talk actually.
Thank you,
Then,
sir.
like actually, another two talks are there. No?
Yes, sir. There are two more talks.
Please, no questions are there in the this one chat box or in YouTube also. Please carry on with the next two lectures.
Dr. Nazreen, you can take over now.
Is my screen visible?
Yes, your screen is visible, Nazreen.
Thank you. Good evening, everyone. The topic I'm going to be talking about today is parapharyngeal tumors and its management. So coming to the topic proper, just a brief recap of the anatomy. So parapharyngeal tumors, as the name suggests, are tumors occupying the parapharynx, which is the area adjoining the pharynx. So basically, it's like an inverted pyramid, and the superior aspect is at the skull base, and the apex is at the hyoid bone. And medially, like I mentioned before, is the pharynx, which includes both the oropharynx and the nasopharynx. And posteriorly, we have the cervical vertebrae and the paravertebral muscles. And laterally, we have the mandible, the deep lobe of parotid, and the medial pterygoid muscle. So this is roughly what the parapharyngeal space anatomy is all about. What is even more important is that here the shaded area is the parapharynx, and there are critical neurovascular structures which occupies the parapharynx, including the internal carotid artery, the internal jugular vein, the lower cranial nerves such as the 9th, 10th and 11th cranial nerves, and also the cervical sympathetic chain. Coming to pathology, although these tumors are very rare, the good news is that the vast majority of them are benign, which is roughly about 80%. And amongst these benign tumors, the most common are the salivary gland neoplasms, which arise from either the deep lobe of parotid or also from the de novo minor salivary gland tissues which are present in the parapharynx. The second most common tumors are neurogenic. For example, schwannomas of the lower cranial nerves or the cervical sympathetic chain. And the least common are the paragangliomas, especially the carotid paraganglioma and the vagal paraganglioma. And roughly the remaining 20% are malignant. Moving on to the clinical presentation, since it is a hidden area, usually these patients are asymptomatic. Now, as the tumor increases in size and when it's roughly around 2.5 to 3 centimeters, the patient may present to you with a neck swelling. Further medial progression of the lesion will cause the typical intraoral swelling, which is typically seen in the region of the soft palate, pushing the soft palate medially. The patient may also have cranial nerve palsies, such as hoarseness of voice due to a vagal palsy or deviation of tongue. Now, moving on to evaluation, what we need to do here is a multimodality evaluation. Initially, we need to do an imaging either with a contrast CT scan or ideally with an MRI. Because as you all know, MRI gives better soft tissue delineation. We will know the size of tumor, the extent of tumor, the relation to the critical structures such as the carotid and the IJV, and also whether it is attached to the deep lobe of parotid or not, and how much contrast enhancing the tumor is on MRI. Now, after doing an MRI, if it is related closely to the carotid and the IJV, we may also need to do an MR angiogram to see how much it is encasing the great vessels. Once we rule out paragangliomas, we can go ahead with a cytology, which is FNAC from either the neck swelling or the intraoral swelling. In the second diagram, the yellow area is what depicts the parapharyngeal space, normal parapharyngeal space. So based on radiology, we will usually have a differential diagnosis. How do we come to this diagnosis? It is mainly by the displacement of the parapharyngeal space fat and the internal carotid artery. So based on this, we will know whether the tumor is in the retrostyloid space or the prestyloid space. Now, after this, we look at other features such as the presence of flow voids, splaying of the ICA and the ECA, and then we can come to the remaining diagnosis, which is paraganglioma or schwannoma of the cervical sympathetic chain, vagal tumors, or even carotid body tumors. So in this image, this blackish area is the parapharynx. And this is usually in a normal person, it is occupied by the fat, which is what appears as black. Now coming to management, the mainstay of treatment in parapharyngeal tumors is surgery. So like I mentioned before, because of the critical neurovascular structures which involves the parapharynx, it is an anatomically complex area and therefore the rate of post-surgical complications is as high as 50%. There are a variety of surgical approaches available to address parapharynx. And due to the benign nature, so like I mentioned before, majority of tumors involving the parapharynx are benign. So we should always attempt to minimize the surgical morbidity. Now, how do we do this? One is by having an accurate diagnosis. We should have a definite diagnosis whether it is a malignancy or a benign lesion we are dealing with. We should have meticulous preoperative planning while radiology review. And we should choose the surgical approach in relation to our target area because it's a huge space. So in relation to where the tumor lies, we have to choose the surgical approach. Now coming to various approaches to parapharyngeal space. So these are all the traditional approaches to the parapharyngeal space. There is a more common one, which is the transcervical route. There is a transcervical and a transparotid route, transcervical, transmandibular, and there is also the transoral approach. Now, what I would like to tell you here is that when there is no gold standard approach or a gold standard surgery to address parapharyngeal tumors, It means that we have various permutations and combinations by which we'll have to do the approach as a tailor-made procedure. So whenever the treatment of something has n number of options, then that means that one particular treatment is not good enough to address all the pathologies involving the parapharynx. So I'll just briefly talk regarding all the different approaches. So in this imaging, we can see that the tumor in the parapharynx has a clear delineation from the deep lobe of parotid. This blackish area which you can see shows the plane of the tumor separating it from the parotid gland. So although the preoperative FNAC of this patient was a pleomorphic adenoma, intraoperatively it looked like a schwannoma. So in the transcervical approach, we use a curvilinear incision 2 finger breadths below the mandible, and it starts from the mastoid tip and it goes till the hyoid. So this is after we raise the subplatysmal flaps, delineate the sternocleidomastoid, the digastric, and here the carotid has been taken in, vascular control of the carotid has been taken in the vascular loop. This is the hypoglossal nerve, what you can see here. And anteriorly will be the submandibular gland, which can be excised if you need additional exposure, or it can be retracted. So here is the tumor. Now coming to the advantages of transcervical approach, it has fairly good cosmesis because we are using a skin crease incision. It is mainly useful in inferiorly placed tumors. It can be combined with other approaches. There is usually no delay in oral intake after surgery, and there is no risk of facial nerve palsy. What are the disadvantages? It has blind exposure both superiorly and medially. Coming to the next approach, which is transcervical transparotid. So it obviously, in addition to transcervical, since we are having a transparotid exposure, there is better exposure, and it is mainly useful in tumors which arise from the deep lobe of parotid. The disadvantages, as you can predict, is the risk of facial palsy. Now, this is a case of pleomorphic adenoma from the deep lobe of parotid, which is clearly visible in the MRI. And since it is a pleomorphic adenoma benign pathology, we decided to go in for a parotid transcervical. So the transcervical incision has been extended in the preauricular area, and we have delineated all the critical structures such as the submandibular gland, the sternocleidomastoid, the digastric, the hypoglossal nerve. And here we have delineated the facial nerve. Since the facial nerve function of the patient was normal, so we have tried to preserve the parotid and the remaining branches of the facial nerve. And the part of the parotid which is caudal to the facial nerve was addressed. So this is the exposure of the tumor in this case. The muscles attached to the styloid apparatus can be divided if we need further exposure, and which has been divided in this case. And here, as you can see in this video, we are dissecting the tumor from the deep lobe of parotid. So since we've already delineated the facial nerve trunk, we are safe. Now coming to this second case, in which it is a high-grade mucoepidermoid carcinoma. So in this case, the patient already had a grade 6 facial palsy, and therefore no attempts were made to preserve the facial nerve. So here we can see the parapharyngeal tumor is arising from the deep lobe, and it is excised in toto along with the remaining superficial lobe of the parotid. Now coming to transmandibular approach, it has excellent exposure to especially to the superior aspect of PPS because we are getting an end-on view to the parapharyngeal space. What are the disadvantages? We may need a tracheostomy preoperatively. The cosmesis is relatively poor compared to the other approaches. Patient may have malocclusion because of the mandibulotomy, and there is a delay in starting oral feeds roughly around postoperative day 5. So here we have taken the transcervical incision in the lip split incision and then continued it along the floor of mouth. And we are planning the mandibulotomy here, and we've also marked the drill holes so that there is no malalignment. And this is the exposure to tumor which we get post mandibulotomy. And here we have refixed the mandibulotomy using mini plates, and this is the cosmesis after surgery. Coming to transoral, it's useful in cases of small tumors, which is confined to the middle part of parapharyngeal tumors with great medial extension and limited lateral extension. So here we use a curvilinear incision from the anterior tonsillar pillar to the soft palate. We dissect the tonsil medially, and then we identify the superior constrictor muscle and incise the superior constrictor muscle vertically, and we get the exposure of the tumor. Coming to, there are various recent advances. There is robotic transoral, there is transnasal, transpterygoid with the use of endoscope in transoral approach, and also intracapsular dissection using debrider. So the decision making in choosing the approach depends on the nature of pathology, whether it involves the pre or post styloid compartment, what is the superior extent of tumor, and what is its relation with the carotid and IJV, and also does it have a plane with the deep lobe of parotid. So this is a roughly an algorithm wherein which we can choose the right approach based on the pathology and also what our intent is. So recently there has been a compartment exposure concept also, which has been put forth by Dr. Sampath Chandra. So he has divided the parapharynx into upper, middle and lower. Upper parapharynx is from the skull base to the inferior aspect of lateral pterygoid muscle. Middle one is from the lateral pterygoid inferior aspect up to the inferior aspect of medial pterygoid muscle. And lower one is from there to the hyoid. So transnasal is good for upper parapharyngeal space. Transoral is good for middle parapharyngeal space. Transcervical is good for lower as well as for complete parapharyngeal space. And if the tumor involves a single compartment, we can use a single corridor. If it involves multi-compartment, we can use multiple corridors. So if there's anybody who is interested in further knowledge regarding the various approaches, this is a fairly good paper, which is a cadaveric study wherein they have again, divided into upper, middle and lower parapharynx. And also they have compared all the different approaches available with regard to what we are exposing. So with this, I come to the end of my presentation. Thank you, everyone. I now invite Dr. Rudra Prakash for his presentation.
Thank you, Dr.
Thank you so
Nazreen.
much, Dr.
Wonderful talk.
Nazreen.
Thank you, Dr. Rudra Prakash. Please go ahead and share your screen and start.
Yes, sir. So
Before
is my screen
Rudra
visible? Am I audible?
Yeah, you are visible, you are audible. Just before that, one more small information. After
Sure.
your talk, Professor Anjali ma'am's talk is there on management of DTC. Ma'am is free
Understand.
from now. She has finished her surgery, and ma'am is she's gracious enough to join us. So after your talk, madam will talk. Okay.
Sure, sir. Thank you so much, sir. So I understand we are a bit short of time, so I will try to move on fast. I'll be discussing about the pre-malignant and the malignant lesions of the oral cavity. So by WHO definition of pre-malignant lesion, it is described as a morphologically altered tissue in which cancer is more likely to occur than its apparently normal counterpart. So the different and what is the definition of a pre-malignant condition? So condition is basically a predisposition, a generalized predisposition for the pre-malignant lesions to occur there. So now we are all aware of the pre-malignant lesions of the oral cavity. The most important ones I have enlisted, which include leukoplakia, erythroplakia, candidiasis, carcinoma in situ, submucous fibrosis, and lichen planus. These are the ones which we commonly encounter in our OPD. Now we are all aware of the etiological factors. More common in the Indian subsetting is smoking, alcohol, tobacco in any form. Then avitaminosis and malnutrition, dental caries and sharp, ragged edges of the tooth. Viral infections like human papillomavirus, environmental factors like long exposure to UV radiation, long-term immunosuppression, as seen in post-transplant patients or in HIV infection patients. So, starting with the first one is leukoplakia, which is a predominantly white lesion of the oral mucosa that cannot be characterized as any other definable lesion. Now, we all know that leukoplakia is a clinical diagnosis. So, as we can see in the diagrams, the first one, the most common site is the buccal mucosa. The other common sites include the tongue and the lip. So, it is usually seen as a well-defined, flat, whitish lesion which you cannot be scraped off. So it can be either homogeneous type or it could be non-homogeneous type of leukoplakia. Other varieties include the speckled nodular and the ulcerative type. Other common but more aggressive variety of leukoplakia is known as the hairy leukoplakia, which is usually associated with Epstein-Barr virus, and it is usually seen in HIV positive individuals. Now, the risk of malignant transformation in a patient with leukoplakia ranges from 0.3 to 10%. Now, although this condition is more commonly seen in men, but we can see that the risk of malignant transformation is seen higher in women, which accounts for 6%. Now, what are the treatment options of the patient? So treatment options include, first of all, is removal of the offending agent. Conservative therapy like vitamin A has found a prominent role in the treatment and reversal of leukoplakic lesion. If all fails, then the option of wait and watch or a cold steel laser or a cryotherapy option can be given to the patient. Now, moving on to the second entity is known as erythroplakia, which is any lesion of the oral mucosa that presents as a bright red velvety patch or plaque, which is unrecognizable from other conditions of the oral cavity. The most common site being the buccal mucosa, floor of mouth, and the retromolar trigone, more common in males 6 to 7 decades. The more important thing to understand in erythroplakia is that the risk of malignant change is 17 times higher than leukoplakia. And here we have to straight away give the option of surgery to the patient as there is no role for any conservative management. The next condition is known as submucous fibrosis, wherein because of the chronic irritant exposure, there is continuous inflammation and fibrosis of the lamina propria and there is atrophy of the epithelium. The risk of malignant transformation in submucous fibrosis is between 3 to 7.6%. So here we can see that the patient might present to us with reduced mouth opening and a whitish glassy mucosa of the oral cavity with fibrotic bands. There are three stages of submucous fibrosis, which starts with this stomatitis or the stage of inflammation, followed by fibrosis, and the stage of sequelae and complication like a reduced mouth opening. Now, the treatment options that are available for submucous fibrosis are local and then surgical options. We can try a combination of vitamin B complex, vitamin E, local steroids, and then topical and both infiltrative steroids along with hyaluronidase. If the conservative management fails, then we can give surgical options to the patient, which include coronadectomy and temporal muscle myotomy, or removal of the whole buccal mucosa on the bilateral side of the oral cavity, which is basically known as resurfacing of the oral cavity, and using some kind of locoregional flaps like a bilateral nasolabial flap, which we can clearly see in this diagram. And the mouth opening in the post-op period gradually improves from 1 to 1.5 fingers to 3 to 3.5 fingers, which is in the normal range. So lichen planus is another entity which is associated with the oral cavity and carries a malignant risk. So we all know lichen planus presents like whitish purple striae and violaceous striae. The common sites include buccal mucosa and the tongue. The treatment options for lichen planus includes local steroids and immunomodulators like Kenacort and levamisole, prednisolone. The recent new drug which can be used for lichen planus is tacrolimus ointment and has shown good response. So it keeps on waxing and waning. We cannot offer a cure to the patient, but we can definitely offer some sort of control. The next most common thing which we see in our practice is oral thrush or candidiasis, which is caused by Candida albicans. So it presents like a curdy whitish covering over the affected area, be it the tongue or the buccal mucosa, which once if you try to peel off will start bleeding from points, multiple points. So the treatment for these are oral and topical antifungals. And most of the time the patient responds and the underlying comorbidities have to be taken care of. Moving on to the malignant lesions of the oral cavity, the most common site which is usually involved is the tongue and the buccal mucosa and the retromolar trigone. Now we have to understand that Indian subcontinent is more affected and the most affected region in the world with oral malignancies. And the survival rate is mere 52% in loco-regionally advanced cases. So like I said, the most common areas are the tongue and the buccal mucosa. Most of them are of squamous cell carcinoma variety. They might present as non-healing ulcer or a simple indurated lesion, a hot potato chewing voice, trismus, or with a cervical lymph node enlargement. Now, the diagnosis has to be clinico-radiological, and a tissue diagnosis is a must before proceeding on to offer any kind of management. So tissue diagnosis is done by biopsy, clinico-radiological assessment and staging is done, following which the patient is then planned for further management. So this is the TNM staging where we define the T1 and T2 stages as the early disease, whereas T3 and T4 are defined as loco-regionally advanced cases. This is again a TNM classification of the nodal disease. So now what are the treatment goals in cases of carcinomas of the ovarian cavity? First is to eradicate the primary and the lymph node mets, and second is to maintain the function and the cosmesis. So on the left side of the screen, you can see what a T1 and a T2 lesion of the tongue looks like. And on the right side, you can appreciate what a T3, T4 might looks like. So it all depends upon the tumor biology, how the patient presents, how it progresses. So if it's a small lesion which is taking a lot of time, or if it's a small, bigger lesion which has just progressed within 2 months, then it shows the aggressive nature of the disease as compared to the indolent nature in the first one. So this is a similar presentation which we see in the region of the buccal mucosa, a T2 lesion compared to a T4 lesion with involvement of the overlying skin. So a T1 and a T2 lesion, usually surgery followed with neck dissection is usually enough to offer cure. And different studies from the Indian subcontinent and Asian subcontinent say that the early response 5-year survival rate is between 80 to 90%. And for loco-regionally advanced cases, the survival sharply drops down to 40 to 50%. So here I'm sharing some of the experience from my previous institute. So this was a patient of tongue C8. He was T2. We had done a wide local excision along with a neck dissection and an islanded nasolabial flap. You can see the floor of mouth and the tip of the tongue was reconstructed. The patient is almost more than 1 year and doing well. He is still with us. The second patient has a lesion, T1 lesion on the region of the RMT. That's why we had to do a bigger resection and do a marginal mandibulectomy along with a upper alveolectomy and a neck dissection. As you can appreciate, there is a flap in C2. This is the supraclavicular flap. The patient is almost 2 years post-op now, is doing well. So this is a third case here of a lesion of the upper alveolus, and we had done a posterior infrastructure maxillectomy along with a FAM flap and a neck dissection. But this is, I have specifically put this in my presentation that it appears like a small lesion. Our resection was good, the patient was doing fine. But 1 year down the line, the patient had developed lung carcinoma with distant mets. So he was a tobacco chewer. So this is just to highlight the importance why tobacco and any form of tobacco is so harmful and the effects are systemic. So with this, I would like to end my presentation. Thank you so much, sir. If there are any questions, then we can discuss those also.
Like as of now, no questions, Dr. Rudra Pratap. Thanks for finishing in time also. And if any question is there, I will WhatsApp you people
Sure, sir.
individually. And
Sure.
thank you so much. This will be this is live telecasted and this is in YouTube and this is given to many groups, so they keep seeing these videos and then they post questions also. For
Sure, sir. We'll
example,
address all of them, sir.
yesterday's videos, today plastic surgery, they received 10 questions. If anything is there, I will let you all know. Thank you so much again from the head and neck team from SGPGI. Wonderful display of your work as well as wonderful talks. Thank you so much.
Thank you, sir.
Thanks, sir. Thank you so much, sir.
And best wishes for your department as well. So next, coming to the last talk of the day, ma'am has operated and she's joined us. Thank you, ma'am, for joining. And still, I've seen many people connected. If Mohanty sir is connected, I can ask him to chair this session, and ma'am can start sharing her screen.
Thank you, Sabha, and sorry for keeping you waiting.
No, ma'am. It's our pleasure that after such a major surgery, you have joined us and this one. So we thought that you should take some rest and then rest. So over to ma'am for.
Can I share my screen, please allow?
Yes, ma'am. Yes, ma'am. Yes. Yes, ma'am is sharing her screen. Ma'am, Professor Anjali ma'am is professor at SGPJ and she's the unit 2 head, and her main interest is on differentiated thyroid cancer. And
Can you see my screen?
no, ma'am. It's in iPad.
Uh, yeah, it's
We can see your
Sometimes
screen, ma'am.
okay.
Mm.
So now my screen is visible, I hope. My screen is visible, Sabha?
No, ma'am.
Not
It's
yet.
not yet.
Okay. Share.
In case you can send it to my email, Gmail, I can put it. I can share from here.
Now?
Now visible, ma'am. Yes, ma'am.
Okay, thank you.
Clear.
My
Yes.
Mac always troubles me a lot. Okay, thank you so much for bearing with me. And Sabha asked me to talk about management of differentiated thyroid carcinoma. So I think this is thyroid carcinoma is a very common topic. So I would just like to touch upon the newer aspect of the management. So as we all know that thyroid cancer is prevalence is increasing as well as incidence. So if we look at Globocon data to 2024, the thyroid cancer is the 10th commonest cancer in the world. And even in India, where it was nowhere to be recorded among top 20 cancer, it has made an entry. So in fact, if you attend some American Thyroid Association conferences, they would say that the commonest cancer in women is not what you think. So the incidence is increasing, but there is a gross difference in the incidence and prevalence across the nation. And it has something to do with screening as well as maybe real increased incidence. And that could be due to various regions, including ionized radiation and so on and so forth. But majority of these cancers are papillary thyroid cancer, and world over, the incidence of follicular thyroid cancer is going down. And thyroid is a very interesting organ because it has cancer where you have to do nothing, like papillary microcarcinoma. At the extreme extent is anaplastic thyroid carcinoma. So this gives an idea that this is an organ where cancer could be a target for personalized medicine. And we would be touching that briefly in coming slides. So majority of the thyroid cancers so far as differentiated thyroid carcinomas are concerned, unlike medullary thyroid carcinoma, are sporadic. And less than 5% of thyroid carcinoma are hereditary. And the commonest syndrome associated with hereditary differentiated thyroid carcinoma are Cowden syndrome, familial adenomatous polyposis, DICR tumor predisposition syndromes, Carney complex, and Werner syndrome. And papillary and follicular thyroid carcinoma are the common occurrence in these syndrome, and PDTC only makes appearance in DICR tumor predisposition type. Another, the recent knowledge about thyroid cancer is that as clinician, we always know that some of the well-differentiated tumors behave badly and some of the poorly differentiated tumor used to behave in indolent fashion. So the new WHO classification has now classified thyroid neoplasm as continuum. So there are benign lesion, then there are low-risk neoplasm, and then malignant thyroid neoplasm. Low-risk neoplasm include non-invasive follicular neoplasms with papillary-like features, follicular thyroid tumors of uncertain malignant potential, and well-differentiated thyroid tumors of uncertain malignant potential, along with hyalinizing trabecular thyroid tumors. Another important aspect is now the term variant from papillary thyroid carcinoma is removed, and there are various subtypes of papillary carcinoma like tall cell subtype, columnar, and so on and so forth. And Hurthle cell carcinoma, which was this thing we know as Hurthle cell carcinoma, now is subcategorized and separated from follicular thyroid carcinoma and is known as oncocytic carcinoma of the thyroid. Then there are two other high-grade tumors. One is poorly differentiated thyroid carcinoma and another is differentiated high-grade thyroid carcinoma. The differentiated thyroid carcinoma could arise from papillary or follicular subtypes and usually have solid and invasive features, unlike poorly differentiated where insular pattern could be noted. And there is difference in mitotic count. The mitotic count is higher in differentiated high-grade tumors and it is less in poorly differentiated tumors, though necrosis is present in both types, and the prognosis of high-grade carcinoma is slightly worse than the poorly differentiated thyroid carcinoma, though there is no robust data on long-term follow-up to know the definite difference in the prognosis as of now. Then I have put this slide just to emphasize the fact that there is a continuum, like in PTC could generally have BRAF or RET mutation. However, there would be certain PTC type where REST mutations are present, though REST mutation is more commonly seen in follicular thyroid carcinoma, but it's not exclusively seen only in malignancy, and follicular adenoma could also have REST mutation present. So this has a clinical implication, which I would be touching upon shortly. So far as diagnostic workup of thyroid cancer is concerned, not much has changed, and we stick to the old triple assessment system, including thyroid ultrasound, FNAC, and TSH estimation. But it is very important to know that we can't diagnose all the thyroid cancer on FNAC, and there could be certain category of thyroid cancer which would be diagnosed only on final histology. The definitive diagnosis of thyroid cancer on FNAC would be given as Bethesda category 6, and that could be papillary carcinoma or poorly differentiated also. However, there are certain categories like Bethesda category 3, 4, 5, where the incidence of thyroid carcinoma could range from 5 to 75%, but there is no way that we could diagnose them on preoperative basis. So is there a solution? Yeah, there are some solution provided, and this is in form of molecular diagnostic tests or gene assays, and there are various commercially available platform in the market. It's very important to know that as there is the thyroid cancer are not unigenetic phenomenon, and since polygenesis is involved, therefore it is difficult to diagnose even on these multi-gene assays. And basically when we are asking or requesting these gene assay, we are looking for negative predictive value or positive predictive value, depending on the case, whether we want to avoid surgery or we want to go in for surgery. So these also do not provide us with 100% confirmation of the diagnosis. Then if in the cases where diagnosis is done, then there is always a question in malignancy that once a diagnosis is achieved, then we look for staging. But in thyroid cancer, no preoperative staging except for cross-sectional imaging to look for the local regional extent, and operability is required. And inoperability is judged by encasement of carotid artery or encasement of media vessels, for example, brachiocephalic vein or brachiocephalic artery, along with invasion of prevertebral fascia. So it is very important to know that no form of staging investigation or imaging investigations are needed in cases of diagnosed thyroid cancer. Then what is the role of PET scan, which is being requested or offered in majority of the patient with any other diagnosed malignancy. So usually the PET of scan role is restricted in the follow-up of the cases. However, there are some suggested role in preoperative setting, and some authorities say that it could be offered as part of initial staging in poorly differentiated thyroid carcinoma and Hurthle cell carcinoma, because these tumors are as such not radioiodine avid, and these could also be used as prognostic tool in case where patient is having to known metastasis. But as I said, usually these are offered in follow-up setting to assess the treatment response and to know the radioiodine refractory status. Now coming to TNM staging. Once a cancer is diagnosed, we assign the stage, and we all know that in current stage, the invasion to strap muscle has been downgraded, and the tumor with strap muscle invasion are now categorized as T3B, not T4A. The second important aspect is stage grouping. Initially, we were taking as 45 years as cutoff for categorizing as young and old age. Now 55 years is taken, and in young patient, there are only stage 1 or 2, depending on whether patient has metastasis or not. However, in older patient, there could be stage 1 to 4B. And it is very important to know that unlike anaplastic carcinoma, there is no stage 4C. Now coming to management. The three important modalities for the management are surgery, adjuvant therapy in form of radioiodine therapy and TSS suppression. And other therapies are usually used as salvage therapy or in recurrent or radioiodine refractory patients. So far as surgical management is concerned, in high-risk patient, there is no doubt that patient has to be offered total thyroidectomy, but in low risk, there is option of performing hemithyroidectomy as well. And in least risk patient, which are papillary microcarcinoma, meaning thereby tumors measuring less than 1 centimeter, there is option of active surveillance. And this concept of active surveillance was propagated by Dr. Akira Miyauchi from Kobe, Japan. And they have more than, currently, this is a slightly old publication which I have quoted, but now they have more than 25 years of follow-up, and they have seen that these carcinomas grows very slowly, and over 5 to 10 years, the increase in size would be between 3 to 5.5%, and incidence of lymph node metastasis would be 0.9 and 0.11% only. However, there is certain caveat to this active surveillance, and if the tumors are posteriorly placed, are poorly differentiated, and if the patient is young, unreliable for follow-up, then it is better to offer surgical treatment to these patients. In fact, now there is another option which is available that could be offered in the form of microwave ablation or radiofrequency ablation. But if the patient could be put on active surveillance, better to go ahead with active surveillance rather than offering these other solutions, but only time will tell the efficacy of these treatment. So why there is still controversy regarding hemi versus total thyroidectomy? We all know that PTC are very low risk tumor with 2% 20 years mortality. And if there is difficulty in conducting randomized prospective trials, because we would be needing at least more than 3,000 patients in each arm of hemi versus total thyroidectomy, and we have to follow these patients for 30 years in order to know the significant difference. So the conduction of randomized controlled trial is almost impossible. So what do guidelines say? When there are no RCTs, then we fall upon guidelines. So majority of guidelines say that tumor measuring up to 2 centimeter could be managed with hemithyroidectomy, and all these guidelines, including ATA, NCCN, British Thyroid Association, and Japanese Thyroid Association, also state that even that if the tumor is intrathyroidal classic PTC or minimal capsular invasive FTC, we can still go ahead and perform hemithyroidectomy in these cases, with caveat of slightly increased local recurrence, but generally there is no difference in the overall survival of these patients, except for a paper which was published by Bilimoria et al. Long back 2007, where they have shown that there was significant difference in mortality of total thyroidectomy versus hemithyroidectomy. But here you could see that at 10 years, the difference was though significant, but in absolute term, it was not much. And currently we have better ultrasonography techniques to exclude the patients who are having multifocal tumors or with minimal extrathyroidal invasion. So I suspect the current recurrence rate and mortality should not be that much high. And for that also we have to wait till future in order to get definitive answer. So then what about lymph node dissection? Whenever there is a malignancy along with primary tumors, we talk about lymph node dissection. So far as lateral compartment or even central compartment is concerned, if lymph nodes are present, positive, diagnosed either on ultrasound, FNAC or clinical as well, then the therapeutic dissection is advised. There is no controversy about that. However, there is all controversy regarding prophylactic neck dissection, central neck dissection. By central neck, we mean the area between two carotid sheath and superiorly from hyoid bone up to the brachiocephalic artery. So why is this controversy? Because in this area there are many main vital structure, including parathyroid and rectal laryngeal nerve, and as such, adding central compartment neck dissection to total thyroidectomy adds to increased morbidity in form of increased rates of hypoparathyroidism and rectal nerve palsy. And if this operation has to be done as reoperation, then the morbidity is likely to be high. So therefore, people would like to perform prophylactic neck dissection where the chances of or incidence of finding incidental lymph node metastasis is high, and majority of the guideline would recommend that T3 or T4 tumors, if that is present in a patient, meaning thereby if a tumor is measuring more than 4 centimeter or is having extrathyroidal extension, then prophylactic central compartment neck dissection could be followed. It's very important to emphasize that it needs a certain degree of surgical expertise and should not be taken by beginners. So now, what about locally invasive disease? So previously there used to be debate about shave, complete resection of the tumor or window resection, but now there is enough literature available which tells us that complete resection followed by end-to-end anastomosis provide best local control and overall survival in cases of locally invasive disease. Now, what about resection of metastasis? Is there a role of resection of metastasis? Usually in other malignancy, if disease is metastasized to distant organ, we usually don't think about surgery. However, as I said, that thyroid cancers are slow-growing cancer, and even in the face of metastasis, the 5-year survival could range with 20 to 40%. And in cases where people have offered curative resection, this survival could go up to 40 to 80%. So more and more authorities are advocating resection of metastasis if it is feasible. First, it contribute to the quality of life, improve local control, and also facilitate radioiodine therapy. We all know there is a limit to which radioiodine could be administered to an individual, and not more than 800 to 900 millicurie could be administered. In fact, majority of the authority would agree not to administer more than 600 millicurie to an individual. So if something could be removed, that should be removed, and then it facilitate the radioiodine, or it would be the resource could be utilized more optimally. And we, in our department also, we have shown that it is possible to resect metastasis. Even if it doesn't improve survival, it adds to quality of life of the patients. Otherwise, the indication of metastectomy are as age-old propagated indication. If there is impending neurological complication, orthopedic complication, and painful metastasis, then resection is done. Painful metastasis could also be dealt with external beam radiotherapy. Now coming to adjuvant therapy. So how do we decide about adjuvant therapy? So there are risk stratification system. As a medical student, we know of many risk stratification system, starting from AIMS, AGES, matches, and so on and so forth. But it is very important to note that these risk stratification systems are mainly for prognostication. These risk stratification system do not help us in deciding adjuvant therapy or follow-up. So American Thyroid Association has come up with its risk stratification system, and once we have performed thyroidectomy and histology is available, then based on whether the tumor is T1 or T2 type, or whether there is extrathyroidal invasion present, the risk of recurrence increases. So in low risk tumors where the tumor is entirely intrathyroidal and there is minimal extrathyroidal or microscopic extrathyroidal invasion, there is no need of radioiodine. However, in low and intermediate group, the patient has to be put on, has to be given radioiodine ablation, and there is no doubt about high-risk patients who are having extrathyroidal extension and when B tumors and distant metastasis, that these patient has to be mandatory put on radioiodine ablation and radioiodine therapy. So the same thing is summarized in ATA guideline as well. Now the radioiodine therapy could be done with endogenous TSH stimulation by thyroxine withdrawal, or nowadays we have recombinant TSH available, and that helps in preserving quality of life of the patient, because patient don't have to suffer with hypothyroidism for long. And that now we have data to prove that it is equally effective as an option for radioiodine therapy. So essentially the ATA has propagated this data framework for therapy, which is an acronym for diagnosis and surgery, then assessment, and then assessment has to be done at 6 to 12 week post-op on levothyroxine therapy, and that time we have to do TG and anti-TG estimation and imaging, and that would decide how the patient has responded to therapy and whether we need any further adjuvant therapy or TSS suppression. And once treatment is decided, then the next assessment would be for follow-up to look for recurrence. So if a patient is having excellent response, meaning thereby TG is less than 0.2 non-stimulated and stimulated less than 1, then these patients would usually not require a radioiodine ablation. TSH has to be within normal reference range. If there is indeterminate response, where non-stimulated TG is between 0.2 to 1 and stimulated between 1 to 10, then also TSH has to be within normal reference range, and these patients may or may not receive radioiodine. However, in case of biochemical incomplete response and structurally incomplete response, the TSH has to be kept below normal range and suppressed, because we know that thyroid, differentiated thyroid cancers are respond to TSH stimulation, and the growth is propagated by TSH. So we have to keep it suppressed. Then what about follow-up? So nowadays there is emphasis on de-escalation of therapy, and if a patient has undergone hemithyroidectomy, then it is not essential to follow these patients very intensively. The suggested frequency of ultrasound is every 1 to 3 years for 5 to 8 years, and thereafter you could also stop. So far as total thyroidectomy and no radioiodine is concerned, ultrasonography every 1 to 3 years for 5 to 8 years. Then we have to discontinue if TG is within normal range and there is no detectable anti-TG antibody. However, for total thyroidectomy and radioiodine ablation with excellent response, the same criteria needs to be followed up. But if the patient is high risk, then we have to continue follow-up about up to 15 years of age. And then what about radioiodine refractory disease? We know that some tumors don't take radioiodine at first scan also, and some become radioiodine refractory over the time, particularly if the tumors are poorly differentiated, or patient is having skeletal metastasis, which are known to be radioiodine refractory. So there are some targeted therapies, particularly sorafenib and lenvatinib, are already established. Apart from that, we can also recommend mutation-directed therapy like darafenib and selumetinib as well. But it is very important to note that the response rate is not very great with these therapies, and all these have very high side effects. So unless the patient is symptomatic, has progressive tumors, despite metastasis, if patient remains asymptomatic, the target therapies are usually not started. However, nowadays there is one interesting role of these targeted therapy, and these could be offered to patients with locally advanced or unresectable differentiated thyroid cancer in new adjuvant setting to make them operable. Now, one more target which is coming up is PDL1, and the incidence of PDL receptors in thyroid cancer could range from 5 to 20%, and that could also be an interesting area of research. In fact, already this pembrolizumab has been used in cases of radioiodine refractory tumors. The role of chemotherapy is very limited, and when needed, anthracycline, taxane, and even capecitabine has been tried in differentiated thyroid cancer, but this is only in very progressive symptomatic cases, and response rate remains very low. So to conclude, I would only say that with increased understanding of tumor biology and biotechnical advantage, we could expect better customization and personalized management of DTC, and hopefully that would improve outcome of particularly those 15 to 20% high risk patient. Otherwise, as I said, majority of these patients have thyroid cancers remain indolent and could be managed with minimal of surgery without any adjuvant therapy. Thank you so much. And I would be happy to take any questions if there are.
Thank you, ma'am. Wonderful talk as usual. And there's still many people are connected. Talawai, Dr. Talawai, Dr. Vivek sir, Dr. Upender, Dr. Mahalashmi, Dr. Shankar. Any one of you have anything? Dr. Mohanty sir also. So anybody, any comments or questions? And even in YouTube, we don't have any questions. So if at all no questions, thank you again, ma'am, very much.
Thank you so much.
Okay, ma'am. Thank you. Bye. And
Thank
tomorrow
you.
we will have the last day of this con. Anybody? Okay. Thank you, ma'am. Thank you so much.
Thank you.